Shubhra counting.
আমি বলবো
So we are starting now. Good evening. Assalamu alaikum. Welcome to this IPDI Cathlab Universities, the inaugural session, the virtual postgraduate course. I hope the budding graduates in Bangladesh will benefit from this program. We start from A and we are deep to end it. We are very much grateful Professor Cheem, his kind consent to be here as the international patron of this program, and also Professor Abdul, sir, the Secretary General of Bangladesh Cardiology here. Everybody knows Dr. Ken, Director of National University of Heart Center, Singapore, and now President Singapore Heart Center. Before I start, Professor Wadud, please welcome address for the panelists of the participants. Also, Abdul, Chairman of IPDI.
Assalamu alaikum and a very good evening to everybody. This is a real pleasure for Mohsin and myself to welcome all of you in this August gathering. Our aim is to introduce the youngsters, the newcomers, into the procedures of the Cathlab. In this COVID era, we cannot give the hands-on experience, but we can give the knowledge backup that will serve you when you start working in the Cathlab. And knowledge is always power. And if you get the knowledge in a proper way, if it is instilled in your mind how to do a procedure in the very correct way, how to summarize things, how to adapt to a difficult situation, that will be very beneficial in your career. And ultimately that will translate into benefit of the patients as well. We are really grateful that Professor Cheem, a very prominent and eminent cardiologist from Singapore, and very good organizer as well, and who has been always involved with many academic activities. He has consented to be our patron. We're also grateful that the General Secretary of Bangladesh Cardiac Society, my beloved teacher, Professor Abdul, is here at this August gathering in this inaugural session. I hope the audience will be enjoying whatever the presentation we are going to deliver to you through our eminent faculties. And also the elders, our faculties themselves, will also contribute from their wisdom. Thank you everybody and welcome.
Thank you, sir. Thank you, sir. Professor Mirzamal sir also here, Director of NICBD. Welcome you. IPDI Co-Chairman, Professor Dr. Meskat here, and Dr. Khaled Mohsin sir also here. I welcome you. Now I request Professor Abdul sir, Secretary General of Bangladesh Cardiology, please a few words for the fellows or also faculties. Sir, unmute, sir.
Yes. Good evening, and thank you very much for arranging such an program. And it is a novel initiative, I think, on the part of the IPDI for the arranging this session, this is a part of the course, I think, which will be continuing for some few other sessions, and that will help to develop the manual of the cath labs in our country, which is very essential for any interventionist in the working in the cath lab. So I welcome this initiative, and also my gratitude to Professor Cheem to connect with us and the contributors. He is a very familiar face in Bangladesh. So I again welcome him also, and I welcome all the other faculty and the participants and the fellows. With these words, I wish very success of this program. Thank you.
Thank you, sir. Now we requesting Professor Cheem for your inaugural speech, the chief guest to this program. Please, sir, use inaugural speech and for starting our program. Professor Cheem.
Thank you very much. First of all, I'd like to thank Dr. Abdul, Chowdhury, Dr. Manjuda, Dr. Mohsin Ahmed for involving me in this very meaningful IPDI program. I'd like to give us a few words to the trainees who are attending these courses. I always think that interventional cardiologists need to have 5 requirements, 3 responsibilities. And this applies even when you become a senior operator. I think the first requirement as any interventionist must have.
The sound is not clear, sir.
The first requirement, can you hear now?
Yes, sir.
The first requirement for an interventional cardiologist is that you need to have knowledge, as Huay has said. You need to have a knowledge of the coronary anatomy, physiology, the pathophysiology, and to understand the various equipment and devices. Number 2, you need to acquire a certain degree of manual dexterity and technical competence, because procedural expertise will determine the final patient outcome. The third requirement that an interventionist should have is a cognitive skill, where you must be able to develop an investigative and analytic approach to solve problems, especially when you face them in the cath lab in every sort of clinical situations. So you need to be able to apply your basic and clinical knowledge to deal with such problems. The fourth requirements I feel for a fellow or aspiring doctor is that you should have a research approach. You need to have a probing kind of a scientific mind, so that we can all continue to develop and create new knowledge in the betterment of our care of our patient. And the final thing that I think an interventionist should have is a interpersonal communicative skill. You have to develop a ability to listen and to be able to communicate with your patients and your colleagues, because I think it is very important that we are able to keep a sustained therapeutic sound relationship with our patients in order that we can carry out our job best. We must be able to work with our colleagues, with our friends, both local as well as global setting. So these are the 5 requirements that I feel that an interventionist need. Then when you become an interventionist, you have 3 responsibilities. Your first responsibility is that you must stay current in the dynamic field of new technology, new development, as well as new techniques. You have a responsibility to learn so that you can become proficient in them and deliver them appropriately and expertly to your patients. The second responsibility that you should have is that you must impart whatever knowledge and skill to the future generation of interventionists. Because this is how we operate, this is how we pass our knowledge from one generation to another in the betterment of care of the field of medicine. And finally, as interventionists, I feel that the ultimate responsibility is that we have to uphold a medical ethics here. We have to practice evidence-based medicine. We have to keep the patient's interest paramount, and we must never let any decisions be clouded by our own personal financial gain. And for that, I would urge that you will always carry a conduct that is exemplary and that the profession will be proud of. Remember, PCI is a lifetime of learning experience. Ultimately, you will be judged on your skill, your judgment, as well as your experience. But trust me, you will enjoy the journey and you will never regret it. So all the best to you in your training. Thank you.
Thank you, sir. This Cathlab is already 250 participants have been registered. So I'm requesting all the participants, please join the class every day, because after completion of the fellows course, we give the certificates duly signed by the Professor Cheem and also other chairman. Please request join in time. It's a class. Don't miss any class. Though it is in the YouTube, but you should be very much regular in this class. Now I start my Wadud sir. Please I start.
Yes, please go on.
I'm requesting Dr. Nur Alam. He's the proposing cardiologist. He's assistant professor of and ICBD. His talk on patient selection for angiogram, that means indication, and patient preparation for the cath lab. The most first opening talk by the Dr. Nur Alam. Dr. Nur Alam, do you hear me? Please share your screen.
Yes, thank you, Mohsin bhai. Am I audible?
Yes, nicely. Yes. Nur Alam, you unmute yourself.
Yes, can you see my screen?
Everything very fine.
Okay. Okay. Thank you, Dr. Mohsin bhai. Respected Chairperson, Professor Abdul Chowdhury, my teacher, Abdul Shafi Mojumdar, Secretary General of Bangladesh Cardiac Society, my teacher, Professor Dr. Mir Jamaluddin, Director and ICBD, and our respected chief guest, Professor Huay Cheem, co-chairpersons, moderator, panelists, and dear fellows, good evening. It is a great pleasure and privilege for me that I am giving lecture in this IPDI forum in presence of these learned faculties, especially our chief guest, Professor Huay Cheem. I am a big fan of him, and as well as his presence is always inspiring. So let's start. There are two topics in my today's presentation. First one is the patient selection, that means indication of coronary angiogram, and patient preparation for the coronary angiogram. Just I like to draw attention of our moderator, Dr. Mohsin, just two issues. If there is any interruption of the internet connection, you please let me know. And other issues, if I have some more time, please pardon me beyond my allocated time. Thank you. So, indication of the coronary angiogram, clinical conditions, as we know, stable angina, non-ST acute coronary syndrome, ST elevated myocardial infarction, and primary PCI, post-revascularization ischemia, pre-surgery, and patient with valvular heart disease, congenital heart disease, and also congestive heart failure, and few patients of arrhythmia also. And in addition to this, the indication of the coronary angiogram is asymptomatic high-risk patients such as history of previous MI, PTCA, and CABG, ischemic findings on resting or exercise ECG, known or suspected coronary artery disease. So first, indication of the coronary angiogram for ST elevated myocardial infarction. Immediate coronary angiogram. Of course, the primary PCI is for immediate coronary angiogram, and STMI complicated to severe heart failure or cardiogenic shock should undergo coronary angiogram class 1 indication. And also STMI patient failed from fibrinolysis, that is a rescue PCI, should undergo coronary angiogram for rescue PCI class 2 indication. Coronary angiography 3 to 24 hours after fibrinolysis, that is successful fibrinolysis, that means pharmacoinvasive therapy. This is also class 2A indication for coronary angiogram for pharmacoinvasive therapy. And coronary angiogram before hospital discharge, this is a class 2B indication, as many of our patients, we do coronary angiogram after ST elevated MI with or without fibrinolysis in a stable patient before hospital discharge. This is a class 2B indication. And also, if the risks of revascularizations are likely to overweight the benefits, then coronary angiogram should not be done. There is no benefit. Primary PCI should be done within 12 hours duration of onset of symptoms, but there are some certain conditions like hemodynamic instability or cardiogenic shock, recurrent or ongoing chest pain refractory to medical treatment, life-threatening arrhythmia or cardiac arrest, mechanical complication of MI, acute heart failure. These conditions may need more than 12 hour. If that more than 12 hour, then we can do primary PCI. And also an important indication is class 2 indication. A routine primary PCI strategy should be considered in patient presenting lately. It may took 12 to, if the time, if there is no time limit, 12 to 48 hours, within 12 to 40 hours, we can do primary PCI in ST-elevated MI, and this is a class 2A indication. So non-ST-SCS patients are categorized very high risk, and immediate risk. Very high risk patients are should send for coronary angiogram within 2 hours. That is immediate invasive procedure. High risk patients of non-ST-SCS should send for coronary angiogram within 24 hours, early invasive, and invasive procedure within 72 hours for intermediate risks of non-ST-SCS patients. Who are the very high risk patients? Patients with non-ST-SCS having hemodynamic instability or cardiogenic shock, recurrent or ongoing chest pain refractory to medical treatment, life-threatening arrhythmia or cardiac arrest, mechanical complications of MI, acute heart failure, and recurrent dynamic STT changes. These patients are very high risk for non-ST-SCS, and they should send for coronary angiogram within 2 hours, immediate invasive procedure. And high risk patients, non-ST-SCS patients having a CRESS score more than 140, that is very high, that is high risk patient, should send for coronary angiogram with a revascularization procedure within 24 hours. That's early invasive. And intermediate risk patients are NST-SCS patients having diabetes mellitus, renal insufficiency, LV dysfunction, post-CABG, post-PCI, and GRACE score less than 140 but more than 109. These patients should be regarded as intermediate risk and sent for coronary angiogram with a view to with a need for revascularization within 72 hours. That is invasive procedure. This is a 2018 ESC guideline. 2020 ESC guidelines non-ST-SCS, they recommended same as before, but addition of a low risk category, and they recommended that in low risk category non-ST-SCS, coronary angiogram is indicated only after non-invasive test. If non-invasive test suggestive of ischemia, then coronary angiogram is indicated. And they also recommended that in alternate to coronary angiogram, coronary CT angiogram could be done in this low risk group of patients. So what about the revascularization strategy or coronary angiogram for a stable coronary artery disease? As we know, in the year 2019, there was a famous trial, that is ischemia trial, that has been published. The data suggested that the conservative treatment is preferable than invasive treatment in a stable coronary artery disease. And ESC 2018 guideline also recommend that the indication of revascularization or coronary angiogram in patients with stable coronary artery disease is the persistence of symptoms despite guideline recommended medical treatment. There are also other indications in stable coronary artery disease, such as high risk criteria on non-invasive testing regardless of the angina severity. Say in ETT, if a patient in first stage of ETT, there is a remarkable STT changes or ST elevation in AVR or other leads, so these patients should undergo coronary angiogram in spite of having stable angina. And also patients who have been successfully resuscitated from sudden cardiac arrest or have sustained monomorphic ventricular tachycardia or non-sustained polymorphic ventricular tachycardia, this patient also should send for coronary angiogram. This stable angina patient should send for coronary angiogram. What about the indication of coronary angiogram in post-revascularization ischemia? Patient having PCI, suspicion of acute closure or subacute closure of the stent or stent thrombosis should send for angiogram. And left stent thrombosis, that means recurrent angina or high risk criteria or non-invasive evaluation in suspected late-stage thrombosis after PCI, this patient also sent for coronary angiogram. What about the post-CABG patient?
Nur Alam, do you hear me?
No, there is problem with your network.
Just immediate CABG, early post-abortive ischemia and graft failure, if suspicion, the suspicion from symptoms of ischemia. Hello?
Hello? Nur Alam?
Mohsin bhai, can you hear me?
একটু সমস্যা ছিল, এখন আছে।
Okay.
We can hear you now.
Okay, thank you. Okay, just I am starting. Can you see my?
Now, okay, fine.
Yeah.
Nur Alam, do you hear me?
Nur Alam, can you switch over to mobile hotspot?
I am talking. Hello.
It says the network bandwidth is very low.
Is trying to put the hotspot. Mr. Jamal sir, do you hear me?
Jamal Bhai is there. নূর তোমার মিউট হয়ে আছে, আনমিউট করো।
Unmute করো, mute করে আবার
Sorry for the interruption. Mohsin bhai, can you hear me?
Yes.
Now quite clear.
Thank you.
Your
Sorry
share
for the
screen again.
Okay. Share.
I think you have to go back 1 or 2 slides.
Okay, sir. Okay, sorry for the interruption. I'm just telling about post-revascularization ischemia. Can
Yes.
you hear me, Mohsin bhai?
Yes. Oh.
Okay, post-revascularization ischemia. When we will do angiogram in a post-PC patient or post-CABG patient, after PCI, when there is a suspicion of acute stent closure or subacute stent closure, that means within 4 hours, acute or subacute within 1 month, patient presenting chest pain, we can send the patient for coronary angiogram. And also in late stent thrombosis, within 1 year, if patient having chest pain investigation suggestive of ischemia, we can send the patient for coronary angiogram. And what about the post-CABG patient? Early post-abortive ischemia, graft failure, coronary angiography post-CABG is recommended for patients with symptoms of ischemia and abnormal biomarker suggestive of perioperative MI, ischemic ECG changes indicating large area of risk, and new significant all motion abnormalities in echocardiography, and hemodynamic instability. In this case, just after the CABG, we can send the patient for coronary angiogram. If there is lesion is detected, then heart team discussion is needed whether we do PCI or reopen the chest. And in late graft failure after CABG, if patient have chest pain with optimum medical treatment, then we can do coronary angiogram. If there is a lesion, then PCI should be preferred than redo CABG, because redo CABG is always troublesome. What about the recommendation for coronary angiography in patient with valvular heart disease? CAG is indicated in valvular heart disease patients before valve surgery or balloon valvotomy in an adult with chest discomfort or ischemia by non-invasive imaging, or both. So before valve surgery in an adult, if there is no chest pain or there is no ischemia in non-invasive testing, then patient should do coronary angiogram in considering their age, substantial age. As for example, if the patient having valve disease going valve surgery or valvotomy, should undergo coronary angiogram. And for women having a risk factor for coronary artery disease more than 35 years also need to do coronary angiogram before any procedure for valve disease. And also infective endocarditis with evidence of coronary embolization. Recommendation for coronary angiography in patient with congenital heart disease. Before surgical correction of congenital heart disease, when chest discomfort or non-invasive evidence is suggestive of associated coronary artery disease, then congenital heart disease patient should undergo coronary angiogram. And some congenital coronary anomalies are there, and for which patients are going for surgical correction. This group of patients having congenital anomalies of the coronary artery should undergo coronary angiogram. And some form of congenital heart disease like bicuspid aortic valve, mitral valve prolapse, as well as tetralogy of Fallot, this form of congenital heart disease are associated with anomalous origin of the coronary artery. So before going to any procedure, these sorts of patients should undergo coronary angiogram to see the coronary trees. And also unexplained cardiac arrest in a young patient. As we know, there are some abnormal origin and also course of the left main or LAD anomalous origin. So the young patient sudden cardiac arrest, and these patients should be sought out by coronary angiogram. Heart failure. Congestive heart failure due to systolic dysfunction with angina or with regional motion abnormality and or evidence of reversible myocarditis should undergo coronary angiography. And what about the recommendation for coronary angiography in other conditions? Some condition like aortic aneurysm and aortic dissection, when surgical procedure is supposed to be done, then coronary anatomy should know. And hypertrophic cardiomyopathy with angina despite medical therapy, when knowledge of coronary anatomy might affect the therapy. And also if we consider the septal ablation for hypertrophic cardiomyopathy, coronary angiogram should be done to see the septal branches of the left anterior descending artery. What are the contraindications? There are no absolute contraindications to the cardiac catheterization. The relative contraindications are coagulopathy, decompensated heart failure, uncontrolled hypertension, pregnancy, unable to get patient cooperation, active infection, renal failure, and contrast medium allergy. My second part is now it will show few slides for preparation of the patient before cardiac catheterization. Disclosure of need for coronary angiogram. Patients are usually uneasy when you break the news to do cardiac catheterization. So be sure you have a strong indication for doing so with documented evidence. Explain the rationale to patient and attendee. First, clarify the procedure before, during, and after. Probable date and time of the procedure, duration of the procedure, admission procedure, about the expenditure of the procedure, previous day preparation, three anxiolytic, anesthesia, and analgesic, the catheterization lab facilities, intensive care facilities, taking view of gamma ray emitting systems, length of hospital stay, probable outcome and complication, post-discharge advice, all things should be clarified to the patient. Or after admission, treat the patient that indicates your confidence. After admission, physical examination should be done like vitals, heart, lungs, pulses, any significant comorbidity, relevant examination, and in radial procedure, Allen test, Barbeau test, although those are not absolutely recommended, but we can do. Vital parameters should be monitored and pulse points should be marked. And what are the test investigations? Dear fellows, the following test should be done for a patient for preparation for CAGs: complete blood count, ESR, serum creatinine, serum electrolyte, coagulation profile, chest X-ray, ECG, echo, viral markers, hepatitis B, C, and HIV, syphilis test for VDRL test, and blood grouping. Consent, this is important. The procedure indication, name of the procedure, details of the procedure, and should mention the side effects like allergy, bleeding, arrhythmia, MI, stroke, contrast-induced nephropathy, and the death incidence also should be discussed. Statistics of such complication and signature by both attending doctor and responsible patient attendants. The night before or the morning before the procedure, shave, clean, and have a good bath. Better test of metformin. Half the dose of insulin or insulin by checking blood sugar. Take usual heart and blood pressure medicine. Loading dose if PCI is planned. Appropriate antibiotics. The patient might kept 4 hours nothing perorally before the procedure, but this is another thought that there is no difference of fasting or non-fasting before PCI. There are some data that recommended that no need to be fasting. The data, this on paper conclusion is that demonstrate that patients undergoing PCI do not need to be fasted prior to their procedures. There are some issues of female patients, menstruation and pregnancy status. This should be considered. Before sending the patient to cath lab, check for the following things: IV access, blood test, and all investigations. Consent was taken or not, and angiolytic analgesic anesthesia is ready or not. After obtaining all reports in hand, patient will go to the cath lab. Attendants can wait in the waiting room. Dentures, eyeglass, and ornaments should be removed. Patient will be attached to monitor and his all vitals will be recorded. X-rays will be taken with the help of the camera and will be analyzed. Sedation may be used in pacemaker, ICD, or CRTD cases. Inside the cath lab, all necessary instruments and drugs should be available. Check all the instruments in CAG trolley. Flush them adequately with heparin saline. Sterile linen should be used. Regular fumigation of the cath lab. Defibrillator should be checked and should be ready. ACT and ABG measurement tool should be checked. BiPAP support should be ready. Oxygen and intubation and trachea should be checked and updated. Void before taking the patient to the cath lab procedure, and you can, if the procedure is long, condom catheter could be used, or if need to urine measure the urine output, Foley's catheter could be used. And this is the last slide, I think, for patient preparation to prevent contrast-induced nephropathy. We can do pre-hydrate and post-hydrate the patient. If the patient LV function is good, then 1 milligram per kg per hour for 12 hours before and after 24 hours of the procedure. And if the LV function is poor, then half of the dose of the saline could be given. Mohsin bhai, can you hear me?
Yes, yes, very nice.
Thank you. And in summary, so there is one point I want to mention. The ESC guideline, they mentioned that rosuvastatin could be given to prevent the patient for contrast-induced nephropathy. In summary, I can tell that, Mr. Chairperson, coronary angiogram is indicated in acute coronary syndrome and chronic coronary syndrome patients according to the merits of this disease. In stable angina, coronary angiogram is indicated either in persistence of symptoms despite guideline recommended medical treatment or in high risk criteria on non-invasive testing regardless of the anginal severity. In valvular or congenital heart disease, before the invasive or surgical procedure, CAG is indicated if there is chest pain or chest discomfort or there is evidence of ischemia in non-invasive testing. Indication of CAG before the invasive or surgical procedure for valvular heart disease, age for men is more than 35 years, or for women having risk factors for coronary artery disease more than 35 years, and postmenopausal women. Coronary angiogram is indicated in congestive heart failure if there is systolic dysfunction with angina or with regional non-motion abnormalities in echocardiography or scintigraphic evidence of reversible myocardial ischemia. And cardiac arrest survival patients or patients having sustained or non-sustained ventricular tachycardia suggestive of ischemic origin should undergo coronary angiogram. And for patient preparation of cardiac catheterization, 5C is important. C for checking the indication, C for clarification of the procedure to the patients and attendants, and consent, documented consent should be taken, and consent taking session, if is a video monitor, it will be best, and C for complete investigation, and last C for caution, taking all the measures for a patient prepare for coronary angiogram. So thank you for your patience hearing, and sorry for the interruption of the internet. Thank you again.
Thank you, Dr. Nur Alam.
Thank you, Nur Alam. Excellent presentation. There are two questions from in the chat box. First, go for the chat box and comments. Number one, what about the angiographic consent or precaution during this?
Sorry, can you ask again?
Pregnancy or administration, Mr. Peter, during the angiogram or precaution.
Investigation or
patient is the primary PCI during pregnancy or initial period. What precaution is
during the primary PCI?
Mohsin, your language is interrupted. Yeah.
Yeah. Hello. Do you hear me?
Yes.
During pregnancy, or during menstrual period, what precaution you need during angiogram?
Oh, thank you, Mohsin bhai. As I mentioned that there is no absolute contraindication for angiography, but relative contraindication for pregnancy and menstruation. If there is a urgency, say for primary PCI, as you mentioned, primary PCI, we have to do it, but we can put a shield. We can put a shield under the patient that to prevent the radiation. And for menstruation, just we can maintain the hemoglobin level or volume status, putting some saline. We can do coronary angiogram. No absolute contraindication.
Thank you. Abdul sir, please comment.
Dr. Nur,
Yes, sir.
you have said after successful fibrinolysis, within 3 to 24 hours, angiogram is class 2A recommendation. But recently ESC has upgraded it, isn't it?
Sorry,
Even
sir,
after successful thrombolysis, all the patients should undergo routine angiogram, because studies have shown even after successful thrombolysis with a patent artery, if the artery has residual stenosis, it will benefit the patient if we open up the artery very well.
Thank you, sir. Thank you for the supplement.
Khaled Mohsin, sir, do you have this comment?
I have one comment. You have put enough emphasis on consent, but are you happy with the consent paper that you are using at NICVT? Do you think it is adequate? If it is not, do you want to prepare a consent, and then let us show in another program what an ideal consent should be? I think that will be a good idea for all of us.
Yes, sir. Yes, sir. Consent is very important, and they should be optimized and as good as possible, because legal issues and others, doctor safety and patient safety issues are very much important.
I will also draw attention to the audience that at the beginning of the angiogram, the pulse and BP, the Cathlab nurse, circulating nurse should record that in a paper. Again, just after the procedure, again pulse and BP should be recorded. It's done in the private hospital mostly, but I have seen it done rarely in the government hospital. That should be taken care of.
Thank you. Thank you, Nur Alam, for your nice and elaborate presentation. You have explained all the indications of coronary angiography in different clinical settings. It is being observed that some cardiologists are referring patients for CT coronary angiogram, even if the patient has got a positive troponin I acute coronary syndrome. So what do you think about it? Does it comply with the evidence-based medicine? I want your comment. And regarding the prevention of contrast nephropathy, is there any role of sodium bicarbonate saline infusion? Though it is the prehydration is the best option, but recently some guidelines are advocating.
Sir, thank you, sir. Thank you, sir. Regarding your first comment or question, ESC 2020, the updated guideline in non-STSCS patient, they only advocated as alternative of coronary invasive coronary angiogram, coronary CT angiogram in low risk group of patient. Low risk group of patient means patient having previously having ECG changes, but at present no ECG changes. Patient having chest pain, but at present no chest pain. So these group of patient only,
and also troponin negative. They must be troponin negative.
Also, yes, that Khaled Mohsin sir mentioned that troponin positive. These patients should not send for coronary CT angiogram. They should send for coronary angiogram. So these are considered as high risk or intermediate risk, not low risk. So this group of patient having non-STSCS with troponin positive raised should send for coronary angiogram, not for coronary CT angiogram. Regarding your second question, regarding the measures prevention of contrast-induced nephropathy, hydration is the best, but sodium bicarbonate, N-acetylcysteine, and some literature showed some evidences, but so far my concern and I go through the hydration is the main concern. Anybody can add about this?
Professor Mohsin, sir. Professor Mohsin.
Sorry, I was late. So how can I participate in this? But regarding
contrast nephropathy, prevention of contrast nephropathy.
Prevention, so far, no study says that this is the best. So far, like as he said, N-acetylcysteine or sodium bicarbonate, still the hydration is the best way to avoid contrast-induced nephropathy. That I can say.
Can I add
And
something?
some other drug like should avoid metformin. That is another part of that.
Only hydration.
Yeah.
I know that all the trials, every trials show.
No.
Hydration is important.
Mohsin,
Yes.
the most important thing again is the amount of contrast you are going to use. Hydration and the less amount of contrast you can use, these are the two key factors. And sometimes I also say, if the patient is having ACE inhibitor and there is already compromised kidney function, that may be aggravating the situation. Some authorities actually suggesting we may lower it, but there is no clear-cut guidance on the lowering of doses of ACE inhibitor or ARB. And addition of sodium bicarb, some studies are there to support it. Some studies are again showing no clear-cut benefit. So it's a contentious issue.
Thank you, sir. Sir, near dose should be practiced. Less amount of dye for angiogram. I think 20 to 30 ml dye is sufficient for angiogram.
Sufficient, mostly.
Dr. Kaisar, Nasrullah, you hear me?
Assalamu alaikum and good evening. I hear you loud and clear. First of all, I would like to thank the IPDI, especially Dr. Wadud and Dr. Mohsin, for starting this Cathlab manual series for juniors. It's really a legendary initiation of a new event which will teach our juniors, and what Dr. Khan we can say that one aim of ours should be transfer the technology to juniors so that others can get benefited even after we die. Secondly, Nur Alam, excellent presentation. I must appreciate our next generations are much better and smarter than us. And Nur Alam, your presentation was really excellent. I learned a lot. About contrast-induced nephropathy, I say hydration. EF is below 40, give 50 ml per hour. EF is above 40, give 100 ml per hour. Start 6 hours before the procedure, continue of 24 hours. And second important thing, what we say, low amount of diet. Also, I would like to use the Visipec, the non-osmolar diet. So these are the two key factors. Other like NAC or giving some bicarb injection in the saline, it is not proved medically, not scientifically proved. These two are key factors. Thanks.
Professor Meskat Ahmed, sir. Mr. Meskat, sir, do you hear me?
I can hear you. Thank you very much for inviting me.
Lots of questions in the chat box regarding the CKD and angiogram, and serum creatinine more than 3, and lots of chat box.
Sodium bicarb and acetylcysteine, vitamin C, all these things had been on the table for a few times, but none of them had stand the test of time. And now it is said that only rehydration is the mainstay to prevent the contrast-induced nephropathy. There was also a question about metformin, withholding metformin in diabetic patients who are already getting the metformin in order to prevent the contrast-induced nephropathy. The issue is still debated. Some people advocate it, and some people do defer them from getting metformin before the angiogram. And as regards CT scan, the JSC has updated the indication of CT in low risk ACS group. This is class 1 indication, both either the stress imaging or CT angiogram. Both of them are class 1 indication.
Thank you, sir. Dr. Muski, will you comment? Dr. Muski?
One should remember that contrast-induced nephropathy, not necessarily it will happen the day following angiogram. Even it can happen within even first 2 weeks.
72 hours.
So they should repeat it again. The chances of nephropathy may persist even longer than what actually we check it, say, after 72 hours. It may happen even after 7 days.
I may add.
Sir. Yes, sir.
Yeah.
Yes, sir.
You have to avoid the diuretics. Sometimes the people used to use the diuretics to make the urine output increase, but this causes the increased concentration of the blood volume. So the diuretics should be avoided. in the cases of the patients of the coronary angiogram. And this is one of the measures of the avoiding the contrast induced.
Thank you, sir. Moderator, sir, I have asked a question for you. Regarding the consent, but the big issue for the government hospital. Dr. Nur Alam nicely explained all the things, but in the consent form, there is two signs. One is the patient attendance, and is the evidence of the any I think evidence should be signed by the evidence. Sir, you explain the consent form, sir?
You ask me?
Yes, sir. For you, sir. You're the leader.
What is when you tell that the consent form should be signed, you must add the informed consent sign.
Yes.
When you get the sign, what happens in our hospital? The people are asked to give the signatures, but they are not informed. So when you ever say the consent, you have to say inform, and it should be in the mother language, on the patient's part, in Bengali it should be. So this is the thing I can add, that always do be informed consent, and it should be understandable to the patients and his relatives.
Last few days back, Dr. Kaisar said that in the United Hospital, they do the video, all the consent, the video camera, they all explain everything, they recorded in the video. Dr. Mohsin, sir, do you explain this?
No, basically sometime patient attendant who actually initially talked to us, if anything happened, maybe that fellow is not there. Maybe the other attendant will say something. I have not been informed. So this is because actually counseling room has got CC camera. So whenever we counsel the patient, it has been recorded. So for the safety of us, we usually counsel the patient in a counseling room. I think it is for legal issues, because in our hospital, I don't know if anything happened. The patient attendance is so arrogant that it's very difficult to manage. So that is for our safety.
The solution is that with every patient, you should have some recognized attendant. When you take the patient's profile, he writes down the name of the recognized attendant of that patient, their first relative. Then you will get the relief of this arrogance.
Yes. I always ask the attendant what is the relation, and ask for the actually. I say that if that patient do not have actually legal, cannot be a legal guardian, I refuse. I said then you have to bring someone else.
One attendant should be recognized in papers.
I agree.
You will give the consent form. You will. All the things will be explained to him only.
Dr. Kaisar, do you add something?
Jaman is out of flight, I think.
Yes. Mohsin, I would like to add to juniors, especially three things. One is to be a competent clinician or doctor, you need to have three things. One is you have to be a good clinician. You have to know how to do a case, whatever antigen or PCI. Second is you need to have very good communication with the patient and patient attendant. A bad communication or not well explained
mute please. Mute please.
And thirdly, I don't know about the government sector, because government sector is not a big problem nowadays when I work there. But in private sector, you have to have a legal, very strong legal backup of yours, like the informed consent, like you explain in front of CCTV camera. Because with due respect to all my patients and all my attendants, people change. When you explain something, they say not all patients. Some patient attendants say, "Sir, do whatever you like." But when the patient dies or something bad happens, then they change. They say, "No, you have not explained me. There's no talks. He didn't talk to me well." So that's why if there's a document, then it can save you with from the legal issues. And we had so many cases, legal cases, especially me, I have to face. So I've got a very bad experience about 8 to 9 patients. But this CCTV camera saved me a lot.
Thank you, Kaisar bhai. And Dr. Arun Maski, do you hear me?
Yeah, I hear you.
Yeah.
So regarding contrast-induced nephropathy, the standard is use non-ionic dye, which everybody use hydrations, as you said, 1 mg per kg per hour, or if EF is low, 0.5 ml per kg per hour, 12 hours before and 24 hours later. And these are 2 standard things. And contrast-induced nephropathy can occur within 3 days, and it can occur up to 10 days, so we should be very careful. So regarding that VGPA and sodium chloride and acetylcysteine, the studies have shown they are of no use. So
know about anything.
Yeah. So I have one question to you. You talk about a lot of angiograms. You should mention now axis. No?
Yeah.
Which axis? Radial axis.
Yeah.
Nowadays, route is even in PCIs, ESC and our guidelines has says radial axis is class 1 indications.
Yeah.
So it is very important to mention that if you're doing any interventions, now the currently radial axis should be done. It's because the bleeding complications are less, 1. Easy to perform, the duration is almost same. And most important thing is, besides low complications and vascular complications, patient is so comfortable, he can sit and go back home after 2 hours. So this access site is very important. If we add that, it looks very good.
But should the fellows should be at least the femoral angiogram should be done by himself, because femoral for the reflex, femoral is better for reflex and everything. So start from the femoral 50, 100 case, then go for the radial. But it's a problem. Every hospital now go to the radial. So junior is in a great problem to do the.
No, it depends on because in Nepal, I mean, if you do only femoral if you cannot do radial. So if you make a train, that becomes good. There's a worldwide, it's a recommendation is do radial. So if you start radial, and then they can go switch to femoral. So I think that's what I think.
What Mohsin is emphasizing, that femoral sometimes is a rescue way. So you better have a good technique of doing the femoral and preferably do the radial. But if you do not have that, in a rush time, in a critical time, you may not be able to do that well. That's the point he's emphasizing. Our junior should have the clear expertise, or at least doing the femoral. Then go for the radial.
My comment is that you remember the early days, some of the surgeon used to do lap call directly without having any experience of open cholecystectomy. What they used to do, they keep one cholecystectomy, open cholecystectomy operator standby. If necessary, at least the lap call expert can switch to open. So if somebody like a cardiologist, if he cannot do for any reason to radial, at least he should know how to do femoral as an escape. One more issue, actually, you agreed, while doing femoral, yes, knowing the fact that a lot of complication related to femoral access, but many a time we used to do renal angiogram while coming back in femoral access. That part is actually through radial, we rarely do these things. So we miss many of the renal artery stenosis as we are now approaching to radial artery. So if somebody feel that, yes, he may need renal angiogram, he should also keep a selective injection in the renal artery to radial approach. But it will be difficult for a tall person, especially if you go through right arm. it will be easy for the left arm because of the catheter size. So if you feel that you need to check the renal artery in a renal artery stenosis patient on suspicion, it's preferable to go to left arm rather than right arm radial approach. This is my small comment.
Thank you.
Mohsin, should we go for the next lecture?
I think so, Dr. Nur Alam, did an excellent presentation. Really, our starting, they use the opening person doing very well. All the team is going well. Congratulations, Dr. Nur Alam. Our second presenter, Dr. AKM Mmwarul Islam, he will talk on echocardiographic evaluation before angiogram. The most important topics for angiogram, we should do the imaging for the patient. Dr. AKM Mmwarul Islam, please.
Thank you, thank you. Respected Chairperson, dear fellows and the participants, Assalamu alaikum and very good evening. Today I am going to talk about echocardiographic evaluation before intervention.
Can you please share it?
Yes, but please arrange so that I can start my video.
Okay.
Yes. Yes.
Okay, thank you.
We all are familiar with echocardiography, and actually, like ECG, today echocardiography is a bread and butter for the cardiologists. The beauty of echocardiography is that it is non-invasive. Wealth of information can be attained from this easily available modality, and it is reasonably accurate. There are multiple options within the realm of echocardiography, and certainly this is cheap. As you know, the commonly available modalities are transthoracic, transesophageal, stress echo, 3D echo, strain echo, and even myocardial contrast echo. So with these different modalities, we can have so many information and useful parameters before going to the intervention. What are the aims of echocardiography before intervention? And what are the things we should focus especially? Certainly, we have to make or we have to confirm our diagnosis before any intervention, and the hallmark of echo evidence of coronary artery disease is wall motion abnormality, and this can be determined by resting echo, stress echo, strain echo, and like those. Coronary artery involvement, we also want to know this, which coronary artery may be involved. We are interested to know about LV function. Myocardial viability assessment is a crucial thing that can be done with echocardiography, especially the stress echo. We should exclude the coronary artery disease mimickers so that we cannot have the false impression that we are dealing with coronary artery disease. Certainly, we have to know about the hemodynamics of my concerned patient, and we are eager to know about the complications that may accompany coronary artery disease. And today, RV function is equally important, and echocardiography can successfully give evidence of RV dysfunction and so many parameters. Now, the first focus is to assess the wall motion abnormality. Coronary artery disease typically results in regional wall motion abnormality, and this is virtually pathognomonic of coronary artery disease. There may be global wall motion abnormality. Usually, presence of global wall motion abnormality indicates non-ischemic etiology, but certainly there are exceptions. If I am dealing with some patients with multiple coronary artery disease involvement, in that case, there may be global wall motion abnormality. So we have to be cautious regarding the interpretation. What actually we look for during assessment of regional wall motion abnormality? This is usually done visually, and for the sake of uniformity, we often divide the left ventricle into different segments. And the usual practice is 16 segment model, or even nowadays 17 segment models. And the 17 segment model is preferable, as you already know. What are the commonly observed parameters for assessment of regional wall motion abnormality? I am certainly talking about the echo parameters. There are two important parameters that actually we look for. One is endocardial inward motion, and the second one, even more important one, is systolic thickening. So these two parameters are looked for in particular segments. And what are the types that may be observed whenever we are assessing regional wall motion abnormality? The wall motion may be normal, or there may be hypokinesia, there may be akinesia or dyskinesia. Previously, another term was used, but nowadays this is dropped in the guidelines, that is aneurysmal. I think every cardiologist should be familiar with the left ventricular segmental analysis. And this is very important. For the assessment of left ventricular segments, we have to have both the parasternal views as well as the apical views. With the parasternal and apical views, you know that there may be 16 segments or 17 segments involving the whole left ventricle. I am not going into the details of the nomenclature of the segments, but certainly you have to be familiar with this. And in the language of echocardiography, the abnormalities or normality I have already mentioned. As I have already mentioned, that the two most important parameters is endocardial inward motion, and another one is systolic thickening. In case of normal motility or movement, there will be normal endocardial inward motion, and there will be normal wall thickening in systole, and there will be reduction of the thickness of the myocardium in diastole. In case of hypokinesia, this systolic thickening and the endocardial inward motion is reduced, and the cutoff point is 5 millimeter. In case of akinesia, either there will be total absence or there will be very minimum thickening, as characterized by less than 2 millimeter. In case of dyskinesia, there will be actually outward motion of the affected segment whenever the other segments are going inward. In case of aneurysmal component, aneurysmal segment, there will be definite outward outpouching of the affected segment during systole. Echo can tell about the probability of coronary artery involvement. So the coronary artery distribution of the left ventricular segments, we have to know whenever we are assessing by echocardiography. We are mainly concerned with left anterior descending artery, left circumflex artery, and the posterior descending artery. The posterior descending artery, as you know, may come from the right coronary artery or the left circumflex artery. Left anterior descending artery, for the involvement of the left coronary artery, left anterior descending artery, the affected areas usually involve the anterior part of the septum, the corresponding anterior free wall, sometimes including the apex, as well as the part of the inferior wall of the left ventricle. For the left circumflex coronary artery involvement, the typically affected segments will be anterolateral wall of the left ventricle and the inferolateral, that is the posterior wall of the left ventricle. As you know, the modern nomenclature of the posterior wall of the LV is the inferolateral wall, not the posterior wall. This is an old nomenclature. And the last one, that is the left and posterior descending artery, or the PDA, this mainly supplies the inferior part of the septum and the inferior free wall of the left ventricle. And it can be derived from either the LCX or the RCA. Look at this. This is the apical fourth chamber view. And here you are seeing that there is beautiful inward movement of the segments, that is the basal and mid segments of the septum, as well as the basal and mid segments of the lateral wall. But look at the apex. as well as the apical segment of the septum, as well as the apical segment of the lateral wall, there is very minimum inward movement of the affected segment, including the apex. And also, if you look carefully, there is virtually no systolic thickening in these affected segments. So these are the hallmarks of the presence of coronary artery disease in case of echo evaluation. And if you are looking on the right side, this is the apical two-chamber view. In this view, we typically see on the right side the anterior wall of the left ventricle, and on the left side the inferior wall of the left ventricle. If you look carefully, the mid segment as well as the apical segment of the anterior wall are hypokinetic, and the apical segment is virtually akinetic. And if you look at the inferior wall, in the apical region, that is the basal and mid regions, mid segments are well contracted. In contrast to the apical inferior wall, that this apical inferior wall is virtually akinetic. This is not contracting at all. Look at this, the same patient in the previous two echo clips. Here we are observing the apical long axis view. In this view, we see the anteroseptum on the right side, and on the left side, we see the posterior wall of the left ventricle, which is, according to the modern nomenclature, called the inferolateral wall. And as usual, there are three segments in each territory. And if you look at the anteroseptum, the mid segment as well as the apical segments are virtually akinetic, and the apex is also akinetic. This is the video clip from another patient. Here, the parasternal short axis view just has been recorded. And here, if you look at the whole cross section of the left ventricle, these areas are well contracting. In contrast to this area is nothing but the posterior wall of the left ventricle. Sometimes the posterior wall and inferior wall are affected at the same time because of the same coronary artery distribution. Here, there is definite loss of contraction of the affected segment as well as loss of systolic thickening. So, by viewing carefully each of the segments, you can be sure that which of the segments of the left ventricle are mainly affected. And with this, you can differentiate from the acute and the old myocardial infarction. What are the hallmark differentiating parameters? Akinesia is a feature of both acute MI as well as the old MI. Wall thickness in case of acute MI is preserved, that is normal. In case of old myocardial infarction, this is reduced and there is thinning of the affected areas. Echogenicity in case of acute myocardial infarctions is not increased, but in case of old myocardial infarction, this is typically increased, and aneurysm formation is always a characteristic feature of old myocardial infarction, but this is not present in case of acute myocardial infarction. So these parameters can help echo differentiation in between the two states of the myocardial infarction. Now, if you look on the left panel, there is just acute infarction. Just look at the inferior wall. This is the inferior wall of the left ventricle, and this is the basal segment, that is the basal inferior segment of the left ventricle. Here, the thickness is more or less preserved, but there is loss of contraction of the basal segment, and also there is no systolic thickening. There is no inward motion of the endocardium, and also there is no systolic thickening. So this is a case of acute inferior myocardial infarction affecting the basal inferior segment of the left ventricle. In contrast, look at the right panel. Here there is a recorded echo clip. This is the parasternal long axis view. And in this view, this is the posterior wall. And here, this is the septum, especially the anteroseptum. And if you look at the anteroseptum, this area is more echogenic, and certainly this is thinned out and having no contraction, that is, it is totally akinetic. So echo characteristics of old myocardial infarction are present here, and there is just telltale differentiation between the two types of myocardial infarction as evidenced by the two clips you are observing. There are some advanced modality you can just employ during the echo evaluation of coronary artery disease. I am talking about the strain echo, and sometimes the strain echo can give us much information. And just see, this is the story of a 42-year-old man who had recent myocardial infarction, posterior inferior, and his ejection fraction was 48%, and global longitudinal strain, global longitudinal strain was minus 13.7%. We know that anything more than 18% is normal. Here the global longitudinal strain is reduced. Any reduced value means that there is systolic impairment. And if you look at the characteristic, that is the light colored areas are having the less contraction, that is the impaired systolic function. And this is the bullseye display of the longitudinal strain study. And according to this, there is typically right coronary artery involvement. On the left side, this is another patient who is 65-year-old man and who is on maintenance hemodialysis, and his left ventricular ejection fraction was only 28%, and he had left ventricular diastolic dysfunction grade 3, and the global longitudinal strain was severely reduced, just minus 4.5%, and he was having triple vessel disease. Look at the strain imaging pattern, and this is the bullseye display of this patient. There is virtually any good color in the display. The whole area is pale. So there is severe loss of viable myocardium with this patient, and there is virtually no adequate systolic contraction of all the segments of the left ventricle. So we can have just first-hand knowledge whenever we are performing strain echo in case of a patient with coronary artery disease. Now, another very important and useful parameter that determines the overall prognosis of the intervention in case of coronary artery disease is assessment of left ventricular function. And this is certainly proportional to the extent of myocardial involvement or damage. So we are interested in knowing about the left ventricular systolic function especially. Peri-procedural complications are more in low left ventricular ejection fraction. You all know that, and there is no cutoff point for this low ejection fraction. Arbitrarily, 30% may be considered as a cutoff point, but there is no hard and fast rule. Severe left ventricular systolic dysfunction may preclude coronary revascularization, though this is not anything absolute, and this is certainly relative. But measures of left ventricular function we can employ by echocardiography is left ventricular ejection fraction, and certainly another modality that is having a growing interest nowadays is assessment of global longitudinal strain, and even this can complement the information obtained by left ventricular ejection fraction assessment by echocardiography. Look at this. On the left panel, this is the patient with very poorly contracting left ventricle. Most of the segments of the left ventricle are contracting very poorly. And if you see that there is ischemic mitral regurgitation here, such a patient, if you are going to evaluate by echocardiography, these patients should not have direct coronary angiogram unless and otherwise you are performing other assessment for suitability and probable benefit by doing intervention. On the right side, this is also a patient with coronary artery disease as evidenced by lack of systolic thickening and inward motion of the endocardium affecting the apex as well as the apical segments of the adjacent areas. But here, the cavity is not so dilated and the other segments are contracting well. What information we can obtain from the two clips? We can obtain from the two clips that on the left side, this patient should undergo further assessment so that he or she can be sent for coronary intervention. But on the right side, probably this patient can have benefit from coronary intervention without further assessment. Now, another useful modality, that is the stress echo, and this can help in diagnosing coronary artery disease. What is the basic principle? basic principle is that even in presence of significant coronary artery disease, there may be no regional wall motion abnormality in case of resting echo, as you are seeing on the left side. But whenever there is excess stress over the left ventricle or the myocardium, the stenosis that is affecting the concerned coronary artery may be actually flow limiting, just compromising the adequate perfusion needed for contracting well, and ultimately during the exercise or any other means of stress, there will be development of regional wall motion abnormality that was not present during rest. So we can use this for the diagnosis of coronary artery disease whenever there is doubt. On the right side, in case of this patient, the resting echo was just normal, but whenever there was exercising echo, the apical region as well as the apical segments of the left ventricle become akinetic, virtually akinetic, signifying the presence of significant coronary artery disease by means of stress echocardiography. Now, the most important contribution of stress echo in the field of assessment of coronary artery disease is to give information regarding the myocardial viability. I am talking about myocardial viability. What is myocardial viability? Viable myocardium actually denotes dysfunctional myocardium, which may recover contractile function either spontaneously in course of time or in response to revascularization. And as you know, there are two types of involvement. One is myocardial stunning and another one is myocardial hibernation. And echocardiography can beautifully identify these sorts of viable myocardium by means of stress echocardiography. Stress echo can detect stunned and hibernating myocardium and determine suitability for revascularization. This is very important because revascularization or even diagnostic coronary angiogram is an invasive procedure. So before going to any intervention, you have to be sure that you are going to do some benefit for the patient. If there is no chance of benefit, there is no reason for doing intervention. So stress echo can give you multiple information regarding this. What are the commonly observed parameters that are useful for assessment of myocardial viability? Mainly two parameters are observed. One is wall thickness, another one is contractile response in case of dobutamine stress echo. Look at this. How can interpretation be met by means of stress echocardiography? The diastolic wall thickness, if less than 5 millimeter at rest, indicates non-viability. This is virtually pathognomonic, but if it is supplemented by absence of contractile response to dobutamine, there is additional confirmation that or confidence that you are dealing with non-viable myocardium. Now look at the left panel. Here, in plain language, the interpretation of stress echo. In case of normal myocardium, there will be good contraction of the segments during rest as well as during stress. In case of ischemic myocardium, it will contract well during rest, but whenever excess stress is employed, there will be loss of contraction or reduction of contraction. In case of viability, there will be no or almost no contraction during rest, but whenever you are performing dobutamine stress echo, that is you are employing stress, there will be contraction. This indicates that the myocardium or the affected segment is viable. And if there is no change in contractile response in case of both rest as well as during stress, this indicates that there is total necrosis, or in other language, there may be scar formation. So there is no chance of benefit from revascularization, whatever modality you are going to employ. Sometimes we deal with end-stage coronary artery disease. I am talking about cardiomyopathies. In case of end-stage cardiomyopathy, that is the coronary artery disease, echo can beautifully differentiate between ischemic cardiomyopathy, non-ischemic cardiomyopathy, and myocarditis. And you have to have some idea regarding this. In case of both types of cardiomyopathy, there will be chamber dilatation. In case of ischemic cardiomyopathy, usually the left ventricle is dilated, and in case of non-ischemic cardiomyopathy, all four chambers are typically dilated, but there may be variation. In case of myocarditis, all four chambers are affected, but loss of contraction or wall motion abnormality will affect globally. In case of DCM, it is also global, but in case of ischemic cardiomyopathy, there will be regional involvement. That is, one or more segments will be preferentially affected, and there will be regional wall motion abnormality. Other walls may contract relatively well. Segmental thinning or scar formation are the hallmarks of ischemic cardiomyopathy, but they are not present in case of non-ischemic dilated cardiomyopathy, and also absent in case of myocarditis. Chamber dilatation, as I have already mentioned, left ventricular ejection fraction are reduced in all types of abnormalities. Right ventricular function is usually maintained in case of ischemic cardiomyopathy, but in case of dilated non-ischemic cardiomyopathy, they are usually reduced. That is, the left ventricular function, right ventricular function is usually reduced. In case of myocarditis, right ventricle may also be affected, and there may be reduced right ventricular function as well. Intracardiac thrombus may be present in all the three conditions. Aneurysm formation is a feature of ischemic cardiomyopathy, but in case of non-ischemic dilated cardiomyopathy and in case of myocarditis, there will be no aneurysm formation. Pulmonary artery systolic pressure will be commonly raised in case of ischemic cardiomyopathy as well as in case of dilated non-ischemic cardiomyopathy, and there will be, if at all, rise. It will be less commonly observed in case of myocarditis. Global longitudinal strain of left ventricle will be reduced in all the three conditions. So if we carefully look for the available parameters, we can differentiate between the three conditions with much confidence. Just look at the two clips. On the left side, you are seeing a dilated left ventricle, and certainly there are some akinetic and thin segments, and the other segments are contracting relatively better. The left atrium is also dilated, no doubt, and you are seeing echocontrast, spontaneous echocontrast within the cavity of the left ventricle. If you look on the right heart is of normal dimensions. That is, the right ventricular diastolic diameter is normal, and you can just qualitatively assess that right ventricle is having good contractile function. Right atrium is also not dilated. This is the typical features of ischemic cardiomyopathy. But if you look on the right side, the left ventricle again is dilated, but here the left ventricle, all the segments are more or less affected, including the apex. The left atrium is dilated, but if you look at the right heart, the right atrium is dilated and the right ventricle is also dilated. How can I tell this? Because I am comparing the right ventricular dimension with the left ventricular counterparts, and the dimension, left ventricular end diastolic dimension and the right ventricular end diastolic dimensions are virtually equal. So right ventricle is definitely dilated. And if you look at the annulus, the right ventricle is contracting relatively less, indicating that right ventricle is having systolic dysfunction. And whenever we interrogated the condition, this was the case of a Graves' disease, and the patient was having left ventricular ejection fraction 18%, and the TAPSC was just 8 millimeter, indicating concomitant presence of right ventricular systolic dysfunction. And on the left side, the 65-year-old lady with old myocardial infarction was having moderately severe left ventricular systolic dysfunction, 30 to 35%, and the tricuspid annular plane systolic excursion was just 23 millimeter. Anything more than 18 is normal. So the right ventricular function is preserved here. Assessment of hemodynamics is another important duty of pre-intervention echocardiography, because in presence of significant hemodynamic alteration, you may not proceed for further intervention at that time without optimizing the parameters by optimizing the medical management. I am talking about several important parameters like presence of left ventricular diastolic dysfunction if it is advanced, left ventricular end diastolic pressure, left atrial pressure. Especially these parameters can determine the prognosis, and the timing of intervention may be influenced by the abnormalities of these parameters. Just look at the left side, left panel. Here, just we are seeing a patient with ischemic cardiomyopathy, and here there is evidence of altered EA ratio, and just the EA ratio was more than 2.7, and on the right side the E by E prime was just around 20. Anything more than 14 or 15 is very abnormal, indicating high rise of left atrial pressure. So we are dealing with a patient with advanced left ventricular diastolic dysfunction, as well as the presence of raised left ventricular pressure. You know that the left ventricular pressure is the surrogate marker of left atrial pressure is the surrogate marker of left ventricular end diastolic pressure. So there is increased left ventricular end diastolic pressure as well. And we are obtaining all these parameters non-invasively by doing just echocardiography without imposing any pain to the patient. The forgotten chamber, just I am talking about right ventricle. We can have useful information by assessing the right ventricle carefully regarding the presence of regional wall motion abnormality, and as well as the pattern of coronary artery supply. We can just judge and have a idea regarding the involvement of the right ventricle by the coronary artery concerned. Now, a few words regarding coronary artery disease mimickers. Sometimes we may be in trouble regarding the making the appropriate diagnosis. The clinical presentation, even the ECG, may indicate that I am dealing with a case of coronary artery disease, but the condition may be actually something else. I am talking about aortic dissection, pulmonary embolism, acute pericarditis, pericardial tamponade, and sometimes the Takotsubo-cardiomyopathy. All these conditions may mimic actually the coronary artery disease. Echo can differentiate these parameters with certain confidence. Look at the clip on the left panel. Here, this is the story of a patient who presented with acute inferior myocardial infarction. And certainly, considering the age and presentation of the patient, we were thinking of proceeding for coronary intervention. But whenever we performed echocardiography carefully, this is the finding of the echocardiography. You are seeing just large dissection flap within the ascending aorta, indicating that here the coronary artery obstruction is not due to any atherosclerotic plaque. Rather, this is by the involvement of the coronary artery ostium due to the dissection. So echocardiography has made the difference for the diagnosis as well as the approach to management of the patient. After management, optimizing the medical management, this patient was sent for surgical correction, and with dental operation, the patient is doing fine even after few years. And this is another case. The patient presented with chest pain, which mimicked acute coronary syndrome, and there was certain ECG changes suggestive of myocardial ischemia. And whenever we performed bedside echocardiography, as you are seeing that there is a large thrombus which has been lost or stuck at the bifurcation point between the at the end of the pulmonary trunk before the bifurcation into the left and right pulmonary arteries. So in this case, echo has made the difference in case of diagnosis. This is needless to say that echocardiography can detect complications of coronary artery disease. Actually, this is the most useful modality and most practical modality to detect the complications associated with coronary artery disease. Why is this important? Because presence of complication can alter the management strategy of the coronary artery disease patients. Just you can encounter ventricular septal rupture, papillary muscle dysfunction or rupture, intracardiac thrombus, pericardial effusion, free wall rupture, and sometimes ventricular aneurysm. This may be true or false. Identification of complications before interventions makes the difference, as I have already mentioned. Just look at the panel on the left side. Here, there is a patient with acute myocardial infarction, and you are seeing non-contractile segments involving the septum, as well as the apex and the apical part of the lateral wall. This is the apical four-chamber view. And if you carefully look for the apical region, there is a large thrombus in relation to the apex as well as the apical segments of the affected walls. So this is the example of left ventricular thrombus. On the right side, this acute MI patient was relatively stable, but at the day 5, this patient suddenly became unstable with severe breathlessness and also shock. And whenever bedside echocardiography was performed, there was a rupture involving the apical part of the septum, allowing intracardiac shunt. So I am talking about the presence of ventricular septal rupture. In presence of ventricular septal rupture, we thought of optimizing the medical management, avoiding any further decision for intervention. Just to look at the left panel, this is the story of a middle-aged man who presented with acute MI, and he was relatively stable. And on the day 4, the patient suddenly became unstable, severely breathless. And whenever echocardiography was performed, at first we just observed that there was significant myocardial mitral regurgitation. And if you look carefully, the mitral regurgitation is certainly severe. And another characteristic feature of this mitral regurgitation is its beautiful eccentricity. That is, the myocardial infarction jet is just impinging on the interatrial septum. So we try to review our observation, and whenever we carefully looked for the further abnormalities in 2D echocardiography, we saw that there is some discontinuity between the papillary muscle and the mitral valve leaflets, indicating that there is rupture of the papillary muscle, allowing non-coarctation and also the eccentric, severe eccentric MR. So this is the example of papillary muscle rupture. Presence of papillary muscle rupture ultimately altered our decision for the further management of the patient, and the patient was put on medical management, and we thought of sending the patient for surgery as soon as possible. And this is probably the last, or the one of the last 2 slides. I am talking about another well-documented and well-recognized complication of myocardial infarction or coronary artery disease. Just look at the cross section, that is the parasternal short axis view at the level of papillary muscle of this patient, and you are seeing that the anterior wall, lateral wall, all are contracting. Even part of the septum are contracting well. There is no abnormality. But if you look carefully at the posterior wall of the left ventricle, there is lack of contraction, rather thinning. And if you look carefully during systolic contraction, whenever the cavity is becoming smaller, this part is having outpouching towards the opposite side, indicating that there is left ventricular aneurysm involving the posterior inferior wall. So this is another complication of coronary artery disease, and certainly this can change the treatment modality of the patient. In place of such types of aneurysm, we can think of rather surgical correction. So I am just at the end of my today's presentation. So what is the take-home message? Judicious use of pre-intervention echo can provide wealth of information non-invasively. Non-invasively, I am giving emphasis. Resting and stress echo can diagnose, locate, and certainly semi-quantify myocardial ischemia. Resting and stress echo predicts coronary artery involvement. Stress echo assesses myocardial viability, indicating suitability and rationality of revascularization. Mind it, this is very important in nowadays. Resting echo 3D echo and strain echo provides prognostic information by left ventricle and right ventricular function. Doppler echo provides hemodynamics, exercising caution before intervention. Otherwise, you can be in trouble. However competent interventionalist you may be. Transthoracic and transesophageal echo excludes coronary artery disease mimickers with confidence. Different echo modalities detect accompanying complications of coronary artery disease, and this is the beauty of echocardiography. Echo is the versatile and efficient tool to safeguard coronary intervention, and this is needed for all the present and future interventionalists. Thank you all for patient hearing. I am indebted to Dr. Shahana Jaman, who is the Assistant Professor of Cardiology of NICPD. And with this, I like to conclude my presentation and thank you all with the beautiful flowers from Bangladesh as well as from Kashmir.
Thank you, Manwar.
Thank you, Manwar. Thank you.
As we began,
Sir.
being not written in the book, in the textbook, compile everything is hard job. Thank you, Manwar. Please stop. Sir, do you hear me?
Yes.
Yeah, please.
Manwar has given us a wealth of information. Why should we do the echo and what points we should be taking care of? And an interventionist, if he cares really for his patient, he should pay attention to the detail that we get, the information we get from the echo. Particularly if we are dealing with a critically sick patient, whether during the procedure the patient is going into acute congestive failure or not. Simple, seeing that the LVEDP is raised, LV filling pressure is increased, we could be careful about using the amount of contrast, and we shall be taking care whether the patient is unsettling during the procedure. All these things we can get a glimpse from the echo, and he has rightly put emphasis on that. Thank you, Manwar.
Welcome, sir.
Thank you, sir. For the junior fellows, you must see the echocardiography before entering the cath lab. 1 week back, echocardiography report is doing by the outside consultant. Please do again in your center, see the echocardiography. Dr. Arif Rahman from USA is the early morning. Dr. Arif, do you hear me?
Yes. Actually, no. It's sorry, I came a little bit late.
Arif, how are you?
Hope everybody is doing well. Juma Mubarak. I'll make this very quick because I have to go to Juma prayer in about an hour. But I just came in the last half of this, and I agree with both you and Dr. Abdul Wadud Chowdhury that it's a very, very nice presentation. And here in the United States, we use echo a lot. It does provide us with a wealth of information. If somebody comes in who's very sick, before we take them to the cath lab, we do a quick ultrasound, and just to make sure what the LVEDP is, what the volume status is. We also try to look at for any wall motion abnormalities and any kind of valvular problems. So yes, it does provide us with a lot of information, and we should use it. It's a very good tool to help us complete the work we do as a cardiologist.
Thank you, Arif. Hello, Professor Meskat, sir. How do you differentiate the hibernating myocardium and deep myocardium?
Echocardiographically, when we get scar tissue, then we know there is no viable myocardium. And as Manwar said, if there is the thickness of the myocardium is less than 5 millimeter and it shows no thickening during low dose dobutamine stress, then again we know that this is non-viable myocardium. But if there is any thickening of the myocardium, it indicates that there is viable myocardium. If the thickening occurs after dobutamine stress, then again we know there is viability. But there are intermediate groups when there is thickening more than 6 millimeter, but there is no increase in myocardial thickening even after dobutamine stress echo. That do not necessarily mean that the patient's myocardium is not viable. So that is the reason where that is the region where we are confused about the viability of the myocardium. But again, if you look at the viability as a whole, global hypokinesia and global viability, then the choice is never PCI, because as Stitch study has shown, even the patient do not have viable myocardium and they go for CABG, then you are going to give some benefit to that patient. So if the viability question comes as regard global myocardial hypokinesia, then it should not be related to coronary angiogram. You got my point? Actually, those are the patient. Those are the patients should go for CABG, and in that case, we do not need to know much about the viability. This is what I wanted to say about the viability. But Mohsin, can we have some use of imaging in patient undergoing coronary angiogram, like looking at the femoral artery and vein, or arterial vein and radial artery or vein, like looking at the dimension of the aorta, so we know which size catheter, especially for the beginners, they know beforehand what kind of catheter he is going to use. Also we can look at the left and right coronary artery, whether they are arising from its normal position. So for the beginner, maybe those will be much more handy. Beforehand, they will be able to know where their artery is, where the coronary artery ostium is, and what is the size of the aorta. This is one of my feeling is like that. And I want to give little emphasis on some chronic cases where Manwar has said that 2D strain may have some role. 2D strain basically do not show the regional motion abnormality, do not have good correlation with region where we get less 2D strain and the region where the affected stenosis coronary artery. But if we have low longitudinal global strain which is reduced, during angiogram we'll have to look for two things. If she is a patient and do have less likelihood of coronary artery disease, and still if you get coronary artery disease normal, then we'll have to look some other parameters during the coronary angiogram, like myocardial blushing and like coronary sinus filling, which will give us some idea about that the patient do have coronary artery disease due to microvascular coronary artery disease. On the other hand, if some patient with very likelihood of coronary artery disease, but coronary artery shows normal, but you get the global longitudinal strain is less, then you should look very carefully to that angiogram, whether that normal angiogram we have missed something in that normal coronary angiogram, like some ostial lesion, like some ostial total occlusion of the diagonal branch or something like that. So it will make more precision about the coronary study. That is what I feel about the imaging and the coronary artery. Manwar has been excellent in showing other things about the wall motion, the viability, and other differential diagnosis, which is extremely needed in patients with acute coronary syndrome. Thank you.
Thank you. Dr. Manwar, there is two questions in the chat box.
Yes.
Choosing of the catheter by measurement of the aorta. How will fellows choosing the catheter size by measurement, seeing the measurement of the aorta in the echocardiography?
I have not gone through any paper, but the common sense is that whenever the aorta is dilated, certainly larger size catheters may be needed.
I think a simple chest X-ray also provides that beautiful information.
Yes. And actually, which approach I encountered during my training in Cathlab is that the decision is taken during the angiography itself.
But usually we use the 3.5 size of catheter, usually in the Cathlab. If it is 30 to 40 millimeter of aorta size, usually instead go for the 3.5 size of catheter. But if it is more than 40, 45, it should be sizing of the catheter is more around 4 or 5, I think so. Khaled Mohsin sir, do you comment regarding this size of catheter? One of the questions for the fellows, sizing of the catheter, choosing of the
in our Asian population, we used to start with a 3.5 JL catheter, but in the European and the American, they start with a Pro. So we start with a half size smaller catheter actually. But if we have a look, if the patient has got a long-standing hypertension or an aortic valvular disease, or a patient is an elderly one, it is better to start with a 4O catheter from the very beginning. So we can avoid the hassle of changing the catheter. But the important thing is to make the catheter tip coaxial with the coronary artery, which size we need. That is very important. We don't want to have a catastrophe by dissecting the ostium of the artery. That is the very important thing. Regarding the one more point. And regarding the role of echocardiogram, it is also very important in the acute setting, because the detailed examination by echo is not always possible, and in those circumstances we need to have some catastrophe. In that case, the operator should use portable echo by himself or herself. This is the very important thing. In the elective setting, there are a lot of good echocardiographers around, and they can give a very good report. But in the acute setting, I think the operator themselves should check the echo before taking the patient to the cath lab table. Thank you so much.
Dr. Mohin bhai, do you have any comments or questions? Professor Mohinuddin.
I wanted to just add one question to Dr. Monwar. The Dobutabin stress echocardiographic results that you have shown in the chart, they are just simple categories: ischemia, then viable, and viable, stunned and hibernating, etc. Sometimes there is, just as the Dr. Meskat has told, there is a mixed picture. There is an indeterminate picture. There is also ischemia as well as a viable tissue, so the picture becomes.
You are absolutely right. I have tried to keep it simple for the fellows.
That's all. Thank you.
You are absolutely right. I have tried to keep it simple for the fellows.
Regarding the catheter side, can I ask Professor Mumnichava sir a question? We see a lot of radial angiogram where the quality of the angiogram is very poor. Is there any specific advice that you should be giving our fellows about what sort of catheter they should be using?
Yeah, very good question. Basically, in a radial, as we are using a single catheter for both right and left, especially sometimes it's very difficult to coaxially align with a single catheter, especially in the dilated aorta. So my suggestion that there is no half-hearted way. Sometimes I see angiogram giving a sinus flush and a big bolus, partially showing the root of the aorta, partly showing the coronary artery. In that case, it will not give a good anatomy of the coronary artery. So in that case, I will advise to use regular Judkins catheter, both right or left, for individual cannulation through the radial artery. Here you can use one size is smaller than what you are using for femoral approach. Say for example, if catheter fit 3.5 for femoral, you can take 3 for radial artery. That is my small suggestion to the fellows. That is, you should do wholeheartedly, not casually. Regarding the lecture, I will really appreciate. There's a brilliant lecture given by Manwar, and I am really delighted with your lecture because all of us, we started our career by doing echocardiography. Maybe I've not been asked to do an echo for last 10 years, but definitely every cardiologist should have their knowledge to know how to do echo. Not for that patient, but for his own planning about the patient management. Because if somebody, say for example, if clinically, we are really nowadays more of instrumental rather than clinical. Rarely we are using a stethoscope on the chest to identify a murmur. We go for the echocardiography. And in a patient with going for planning for angiogram, the echo is something like casual echo. And sometimes I see not even just detail, ejection fraction 40%. I should say it should be detailed and written as a document in detail, not that simple ejection fraction, about chamber dimension, about the valve morphology, about the wall thickness, about the, so detail will help the interventionist, especially for us, we totally depend on echocardiography for echocardiography for pre-procedure echo. Sometimes if any doubt about that, then yes, in cath lab we can use mobile echo, a small handy echo nowadays is available. But in emergency, as one of the panelists said, that in emergency situation, yes, at least you can see, apart from the wall motion abnormality, you can see any regurgitation, any pericardial effusion, any aortic dissection that mimics acute coronary syndrome. That is very important. Even you should see it even in the cath lab. But for regular plan echocardiography, it should be plan angiogram. It should be done properly, as Manwar showed. A lot of things can be identified. A lot of things can be seen non-invasively for taking care of the patient in cath lab. If you know beforehand, I have got a bitter experience of, sorry to say, when I give example to many situations. One of my senior colleague, she is a doctor. We did angiogram. By mistake, the echocardiography missed to identify the exact aortic valve. Just mention aortic valve is thickened. That's all. Surgeon did the bypass surgery. On third day, he is difficult to wean out. And we did the echo. It is severe aortic stenosis. And she had to go a redo procedure to replace the valve after bypass surgery. How expensive in terms of the patient life. So simple, careful echocardiography can help a life event. So that is my perspective from my side. I will say, the fellows, please don't give any shortcut way to do any test. Go in detail. Thank you. Thank you, Manwar, once again.
Thank you. Professor Abdul,
I have a question, sir. I want to ask a question to Manwar, sir.
Yes.
So thank you, sir, for your excellent and meaningful presentation. Sir, sometimes we get patients with LED critical lesions and very low ejection fraction. We refer this patient for viable or stress echo. So what are the risks and how the precaution should be taken before doing this case?
Actually, when should we refer a patient for stress echo?
Right, sir.
I am talking about assessment of myocardial viability. If the patient is having chest pain, that is clinically, if the patient is having chest pain during exertion, no need for myocardial viability assessment, because presence of chest pain is the clinical parameter for myocardial viability. If sometimes we are performing, say, ETT, and there is changes in ST segment, we can make sure that my patient is having, say, myocardial viability. In other cases, when there is a doubt and the patient is having low ejection fraction and the patient is having multiple comorbidities or high risk, in those cases only there comes the role of assessment of myocardial viability by means of stress echo or MPI.
Can I give an example? For say, a patient have angiogram, you have done the angio, find out the LAT is critical occluded. There is another critical stenosis in RCA. Now, if the whole of the anterior wall is akinetic, thinned out, what will be the benefit of doing CABG because of the proximal LED occlusion? What CABG can give benefit to this patient? In that case, opening up the RCA will give enough benefit to the patient. You should have to have meaningful benefit from Lima to LAD graft. Otherwise, why should you open up the artery? In that case, if the viability test shows there are enough viable tissue in the LAD territory because of the pre-existing collaterals from the RCA, surgery will be preferable. A shifted trial has shown in critical patient surgery is still actually better.
Thank you, sir. Professor Abdul, sir. Sir.
Thank you, sir.
Nothing to add. Actually, the Dr. Manohar has made a very exhaustive description of the pre-interventional echocardiogram, and he has got a very good archives, actually very good archives of many video clips, and we have to borrow the video clips from him to make our presentation nice. So thank you, Dr. Manohar, that you can impart the importance of the echocardiography before the intervention to the interventionist. Actually, what happens? Anyone goes to the person of the interventionist, he write down, they have the CAG, have the this and that, but he never advises for the pre-intervention assessment. It's very hardly it is written. I'm sorry to say, just a chest pain, you say that having the CAG. So if the interventionist present here or the persons who are doing the intervention, if they get the message from your lecture, from the presentation that the echocardiography is a very good role before the intervention, then it will be a success, that your presentation will be a success one, and also this session will be a success one. Thank you very much.
Thank you, sir.
Dr.
Kaisar, a simple but important question from Dr. Sudipto Saha. Is it necessary to perform stress echo prior to PCI?
No, not in every case. Only in selected cases.
Selected cases.
Kaisar, look at the me.
Yeah.
One question in chat box. Pericardial effusion. You found report effusion. You proceed for angiogram or angioplasty. But how much effusion you accept before angiogram or angioplasty?
Presence of pericardial effusion is probably not a contraindication for coronary angiography. This is the other evidence, and the amount of pericardial effusion may be a consideration. Just presence of mild pericardial effusion is a very common phenomenon, and you can, I think, proceed. But presence of moderate or huge pericardial effusion, or presence of significant inflammation or other causes of pericardial effusion, you should think of doing any intervention or even diagnostic coronary.
Actually, let me say one thing first. Actually, today, my one wish come true, to hear and to be student of Manohar. I wish to be reborn to be his student. He gave such a splendid lecture, and really, we need people like him, who has got such an ability to teach people. Thank you, Manohar. Thank you so much. About your question, pericardial effusion, if it is mild to moderate, I usually don't, I go for intervention. If it is severe one, I drain the pericardial effusion, then I go for intervention. And secondly, about echo, I must say my experience, we need echo for 3 times: pre-procedure, during procedure, and also post-procedure. Pre-procedure, whatever Manohar said, and also sometimes I get embarrassed because the fellows do echo very hastily. They said EF is now 50% or 50 to 40 or 50%, and after intervention, when the patient comes for follow-up, from outside, then he brings the echo report of 30 to 40% after MI. So patient asked that before intervention it was 45 to 50, now 35. So what happened that the fellow did not do the echo properly. He was in a hurry. This is one. Secondly, during intervention, when you do ASD closure, VSD closure, TAVI, or some complication like perforation by CTO wires, you need to follow up with echo, and especially sometime during the PTMC also. And I would say that now with my experience, I said that we should also know how to look with the echo probe or vascular probe to see whether there is a pseudoaneurysm or retroperitoneal hematoma, because lots of time when you're in problem, not expert people are around you, so you should know these things, and it really helps. And post procedure also, you need to follow up patients sometimes, especially after doing a CRTD, that whether that EF has gone up, or after doing a procedure when the patient follow up, whether my intervention has brought a good result to my patient or not. And thank you, Monwar. Thank you for such a wonderful lecture.
Welcome.
Thank you, Monwar.
Monwar, can I ask you a question regarding this?
Sure, sir.
If post-procedure after coronary intervention, if I want to find out whether it has benefited the patient, when is the optimal time that you want to see the echo report, whether the stand or hypertrophic myocardium has been brought into action?
Sir, thank you, sir. This is a difficult question. The situation will depend on whether I am dealing with stunned myocardium or hibernating myocardium. In case of stunned myocardium, usually the return of contractile function is relatively rapid. It may take several days, maybe. But in case of hibernating myocardium, as this is a chronic process and there is downgrading of all the contractile machineries of the myocardial fibers, it takes longer time, maybe weeks or even months, to
around
harvest
3 months.
the maximum benefit. Right.
Around 3 months.
Yes, sir.
Because we see that for the scar formation and everything, it takes around 6 to 12 weeks to bring down the level of involvement. So take a longer time. But for acute coronary primary PCI, we can see it after a few days. We can see the benefit. Arif, do you want to put in your comment, please?
Yes, I actually have a question. Thank you, Dr. Wadud. So this is more for you experts out there, the CTO experts. We see in the United States a lot that, we have patients who have a chronically totally occluded artery, they have scar tissue, they do a stress echo that shows no viability, but they often complain of chest pain. And then I see these CTO operators will go and open up the CTO. What is your take on that? And what do you think, is there really a benefit when you've already proven by a stress echo that there is really no viability, but the patient is still complaining of chest pain?
Should I answer?
Yes.
I'd like to hear all your opinion, please.
This is a very good question, and this is one Achilles heel for stress echo. One limitation: stress echo has got relatively lower sensitivity but higher specificity if we compare this with myocardial perfusion imaging for assessment of viability.
Sure.
And because of the presence of some islands of viable tissue, even within the scar of myocardium, there may be just assessment of myocardial viability. There is no viable myocardium by stress echo. Here lies the beauty of stress MRI. Stress MRI even can detect the islands of viable myocardium within the scar. And here lies the explanation for your apparent benefit by doing intervention even in presence of lack of viability, as reported by stress echo.
No, that's actually an excellent answer, because in the United States, our practice has been whenever we see a CTO and we have an echo that shows scar tissue, but the patient is still complaining of chest pain, we do a myocardial perfusion viability, or we do a stress MRI to look for rear viability. We do not use a stress echo at that time. You're 100% right. That's what we use in the United States.
Thank you. And the message is that never disregard the pain complained by the patient with myocardial infarction or coronary artery disease. This is the clinical hallmark of presence of viability.
Actually, I want to give one more addition.
Yes,
yeah, just add to Dr. Kaisar's comment regarding the role of echocardiography post-procedure. From our own experience, and it's a routine work for the patient after doing CTO, in echocardiography is a mandatory in CCU.
Yes.
Number
Yes.
one. And also for the patient undergoing pacemaker implantation, because
Yes.
we are using the screwing lead. So we have seen a couple of cases, the patient develop hypotension, everybody is worried about, and they initially they use inotropes, fluid challenge, but here simple echocardiography is enough to identify the reason that there's small pericardial effusion, which was not earlier. Then it grows slowly and patient is going to get immediate go into shock. So post-procedure echo is very, very good tool to identify hypotensive episode in CCU. So in my hospital, it's a routine practice for CTO patient and pacemaker. It's a mandatory to do echocardiography.
And you know, I also want to add, even you're right, Dr. Mominuzzaman, that's exactly correct. Even in the United States, our teaching to our fellows are that anybody who's hypotensive, post-PCI, it could be a vagal response, whatever it may be, you have to get an echo. You get an echo, prove there's no effusion, then you prove there's no RP bleed if you did a femoral approach, and then you worry about vasovagal or other things. But you're right. We also get, and you're right, also for CTOs, for post-TAVR and all that, we get a routine echo immediately post-procedure. So if there's any change in the clinical, we have something to compare it with. So that's a great practice.
Can I make comments on ejection fraction and the revascularization in chronic stable angina? Generally,
Yes,
we do not to look at the ejection fraction after doing revascularization in patient with chronic stable angina, because there is little change in ejection fraction. All that you have to look at is the symptom of the patient. Now, this was my comment about the ejection fraction and the successful revascularization in patient with chronic stable angina. And as regard the stress echo, actually there has to be 80% viable myocardium to give positive stress echo. So if you have viability less than 80%, then the stress echo is not going to be positive. So by no means, if you are going to open a totally occluded LED, please don't look at the stress echo. In that case, you really have to go for the stress MRI.
Do you have stress MRI in Bangladesh?
No.
No.
Okay.
No.
We are on the process of getting one.
Inshallah.
We'll have it within 1 month.
Thank you, sir. As Professor Mohsin Ahmed said, after TPM removal, sometimes there may be perforation. When TPM is done, there is no leaking. But when in the patient shifted to the TPM room after pacemaker, remove the TPM, temporary pacemaker, then suddenly gush of blood to the. So for the fellows, please do echocardiography after pacemaker and after post-PCI. Thank you, sir. Manwar, excellent, brilliant presentation. We are learning a lot, not only participants, all faculty also, and this your presentation. Thank you, Manwar. Again, we are now entering the Cathlab. Now we proceed into the Cathlab. Dr. Anisur Awal start talk the Cathlab, guide to 100% success for access and safe further. Dr. Anisur Awal, Assistant Professor of Medical College. Dr. Anis, do you hear me?
Yes.
Okay.
I have to lead. Everybody, thank you very much. Inshallah, I'll see you next week.
Thank you.
Okay, thank you, Arif. Assalamu alaikum.
Walaikum salam.
Thank you, Arif bhai. Good night.
Okay. Assalamu alaikum and good evening. I'm privileged to be part of this unique opportunity of Cathlab manual by IPDI. Respected chairperson and the panelists, and many of my favorite teachers are presenting here. Mohsin sir, Dr. Kaisar Nasrullah Khan, Meskat sir, Vijayan sir also, and Shafi sir also. So my talk will be Guide to 100% successful femoral access and safe closure. After a solid start by Dr. Nur Alam and a brilliant presentation by Dr. Manwar, my job is a bit difficult one. So my talk, femoral arterial access, most common method of vascular access for coronary angiography and percutaneous coronary intervention, often underestimated, but important aspect of the procedure and is the single most frequent cause of complication during coronary angiography and intervention. Most vascular complications are preventable by following good access technique, starting with a thorough history and physical examination. That's the history. This Andrew Gunjek is in 1977. First percutaneous balloon angioplasty is done by him through femoral route. And in 1927, cerebral angiography by Agus, and Frostman cardiac catheterization 1929, and 1940 Cunard catheterization and hemodynamics. And this gentleman, all of you know that this is Dr. Sons, accidentally injection of the contrast in right coronary artery by Dr. Mason Sons, and he does in 1958. So now the question arises, why we are not talking about the femoral route? Everywhere now there is a craze for the radial route. That's true. We started our career with the femoral route. Now we switch to the radial route because of the less vascular complication and patient choice and the economic. But still there are some roles where you have to look for femoral. And femoral is very important. When you have to do this, you have to do it very, very safely. So that's why you need to know 100% about the all ins and outs of the femoral route. So let's take an example from my own case. This is a angiography of a gentle or pleasant woman. She had double vessel disease and lesion in the RCA and the LAD. And we started PCI, so transradial route, but we completed the fixing the by RCA, but we ended up with a complication in there is a radial artery perforation. We managed this and we couldn't recannulate the radial artery. Then we have to go to the femoral route. So this time we cannot afford to have another complication in femoral route. So under fluoroscopic guidance, hit the femoral artery at the right point and we finish the job successfully. This is another example of the peripheral angiogram. When often we come across the intermittent claudication, limb ischemia, we have to do through the femoral route. And we have done this in our center with 2 stands because of the bulky stand, and we cannot do this by the radial route. And especially even though we're very expert, they cannot also go beyond the knee with the radial route. So femoral is the preferred route of choice for all kind of peripheral intervention. And look at this complex angiogram. This is also last week we have done in our center. This is a CTO of the right coronary artery. And to see the collateral very well, we have to go through the femoral route. And through the femoral route, we have done this and we put 3 stands and you can see the results. So femoral is not a forgettable route. And now I draw to attention of the all young fellows. Those that are young fellows, they will do the TAVR and all structural procedures. And you know, this TAVR and all structural procedures, you need a very high, larger sheet. And the preferred route is the femoral route. So femoral route is not a forgotten route. You need to know it very well. And you have to, is either a bailout or is a preferred route in a complex PCI or in a structural heart disease, you have to go through femoral route. So vascular access is arterial and venous. And arterial, again, you can go through femoral, radial, brachial, and ulnar. Most commonly is the femoral or radial. And venous is also femoral, internal jugular vein, and subclavian. So anatomic consideration, femoral artery is a direct continuation of the external iliac artery, and it bifurcates into the profunda femoris and superficial femoral artery. This is important. We need to hit the femoral artery in the common femoral artery, not above the inferior epigastric artery or not below the bifurcation. So before doing, we have to be in a focus history, whether the patient have any symptoms of peripheral arterial disease, prior intervention for peripheral arterial disease, recent femoral access, closure device used or not, any growing complication, presence of active growing infection, prior surgery, radiation therapy in the groin, whether the patient can lie supine for prolonged periods of time, because some of the chronic conditions like chronic low back pain, congestive heart failure, COPD may limit his chronic lying, and which is required for the femoral route. At the same time, it depends on how you close your vascular. So physical examination, also focus examination in inspection of the groin, whether there is any infection, especially for obese, palpation and auscultation for bruise of the femoral pulse, palpation of the distal arterial pulses, including bilateral dorsalis pedis, posterior tibial, popliteal arteries. We must not forget to do this before the cath lab, because after the procedure, patient may lose the pulse. And if you do not know before that whether it is done before your procedure or after, there may be legal issues arises. So this is very, very important. So ideal femoral arterial puncture site. So as you can see here, as I already mentioned, this is the common femoral artery that lies in between midpoint of the inguinal ligament and the bifurcation. And we want to hit the artery in the just midpoint, because where it is covered by the femoral head and where we can compress the artery very safely. Here, this artery is not only, it is also covered in the femoral sheath. So this is very important. So caudal punctures may cannulate below the bifurcation into the superficial femoral artery or profunda, which may lead to bleeding, hematoma, or pseudoaneurysm. So in case of double wall puncture or bleeding due to inadequate compression occurs in common femoral artery, femoral sheath limits the spread of the hematoma and preventing pseudoaneurysm formation. That's why this is important, where you need a precise puncture. Smaller capillary arteries below the bifurcation also makes them more prone to catheter-related arterial occlusion. Tributaries of the femoral vein course above the superficial femoral artery. So if you accidentally puncture low, when you hit the femoral artery, you can also hit the femoral vein. There is then the question of creating arteriovenous fistula. So you need to take care about this. So ideal femoral arterial puncture site is the femoral, not skin puncture, is the point 1 centimeter lateral to the most medial aspect of the femoral head, midway between its superior and inferior border, which is known as the Roop's rule. The optimal location of ideal femoral arterial puncture is best assessed from prior femoral angiogram. If you have prior femoral angiogram, you can check there. So steps of successful femoral arterial cannulation: conscious sedation and local anesthesia. Often we do not do this conscious sedation. What do we mean by conscious sedation? Patient will be sleepy, but he will be arousable. This is sometimes required for patients, those who are very anxious. You cannot just make them, these are the group of patients. You can use midazolam, or you can use even fentanyl. And after planned site of skin entry by the needle, lower border of the femoral head on fluoroscopy. Nowadays, fluoroscopy, they recommend, they do it. There is no harm. You take one fluoroscopy, no harm, because this can make you comfortable, and this can avoid many complications. Femoral arterial pulsation should be felt with the tips of middle and index finger parallel to the course of the artery. Adequate local anesthesia should be given, starting with the dermal bleb, then you go deep and deepest point. And the best practice when you pull before the push the local anesthesia, you pull back the plunger, so that accidental entry into the vessel can be avoided, and you can avoid the arrhythmias. So there are a question of that some people prefer to do nick and tunnel approach. 2 to 3 centimeter nick is made parallel to the skin crease at the site of the local anesthesia with a scalpel blade, and also they can enlarge it by the tip of the small curved forceps. And the nick and tunnel approach ensures less resistance while the arterial sheath is advanced. The disadvantage of this technique are the failure to cannulate at the site may cause occasional tract losing after sheath is removed. There is an alternate approach. After small nick can be made after femoral artery access with the needle in place. So femoral arterial cannulation. With adequate local anesthesia, femoral access is obtained, and with 18 gauge needle employing the modified cell ginger technique. Cell ginger technique is the puncturing both the wall, then we do. But in modified cell ginger technique, we puncture the only anterior wall. This is the preferred method for the femoral, which is different from the radial one. Radial, we want you puncture both the wall, then you withdraw. There is no harm because there is a bone support is there. So, but in femoral, there is a risk if you puncture accidentally posterior wall. If you cannot compress it appropriately, there may be chance of leaking and the hematoma formation, and there may be catastrophe. So that's why you always try to puncture the anterior wall, especially if you have the plan to do the PCI. So with palpation of the femoral artery, with the index and middle finger, one hand, needle held with the index finger and thumb, with the needle tip weevil facing upward, skin entered 30 to 45 degree angle, and ensure that the artery will be cannulated 2 centimeters superior to the skin entry site. A more vertical entry may be needed, especially for the obese patient, but vertical entry have a problem because there may be kinking, and there may be difficulties in the pushing the catheter and the sheath. Once the femoral artery is cannulated, good pulsatile blood flow should be ensured before any guide wire advancement. After that, you enter the J-tip guide wire, And if you found any resistance, look at the fluoroscopy. Where is the problem? If it is at the tip of the needle, then you can withdraw the wire and reposition the wire when the gush of blood is coming. If resistance is encountered as the guide wire leaves the needle tip, so guide wire should be removed and needle adjusted to ensure brisk flow. Similarly, when the needle is up against the wall, slight repositioning either laterally or medially aids smooth guide wire advancement. In cases in which guide wire encounters resistance in the external or common iliac artery, attempts should be made advancing the guide wire under fluoroscopy, taking extra precaution. And there may be your wire may goes external iliac artery or somewhere other in the branch. So you don't never push. This is the one common rule, never push. And you should see the fluoroscopy, what is the problem, and then you again try, but very gentle and never push. So femoral arterial cannulation, if does not work, especially in patients with tortuous iliac arteries, and J-tip guide wire should be exchanged for a steerable wire. In our center, we use steerable wire. With sufficient length of the wire in the artery, a small skin nick is made at the cannulation needle, is then exchanged for a femoral arterial sheath with the dilator inside it. J-tip guide wire and the dilator are removed, and the side port is flushed with heparin saline. It is better to have a before I'm going there, we should take with the dye, and we can see the femoral artery. And you can see whether there any complication happens, especially if we have any plan for doing PCI. So after that, there is the question of the complications. The complication could be vascular, non-vascular. Vascular, again, hematoma, pseudoaneurysm, arteriovenous fistula, retroperitoneal hemorrhage, thrombosis. Non-vascular is an infection. Though there is a big list, but almost all vascular complications are preventable. So femoral access complication, the rates, as you can see from this figure, the hematoma is only have a big figure. Others are not that much, very common. And all these can be preventable by good access technique. And what are the predictors of vascular complications? Some of the demographic factors like greater age, female gender, low body mass index, high body mass index, and if the patient is receiving anticoagulation, larger heparin dose, thynopyridine, glycoprotein, this is a complex PCI when there is use of glycoprotein 2B3A receptor inhibitors, and intervention done 24 hours of the thrombolytic therapy. These are the high risk patients. Procedural characteristics, when duration of the complexity procedure is more, longer time to sheath removal, major coronary dissection, and emergent priority, stent placement, and some medical conditions where acute myocardial infarction, shock, renal failure, peripheral vascular disease. These are the predictors of the complications. So procedural risk stratifications. When we say low risk, less than 1% complication rate, usually in the diagnostic angiographic procedure. When we say moderate risk, it means 1 to 3% complication rate. These are the routine percutaneous intervention. When we say more than 3% complications are the high risk patient, especially in the primary PCI for acute MI, prolonged multivessel PCI, or procedural that require larger sheath size. So risk factors, some of them are modifiable: size of the puncture, number of the atoms, you can modify this, size of the sheath, smaller sheath, less complication, larger sheath, more complication, sheath removal, and medications. And non-modifiable: age, gender, BMI, associated disorders like CKD. So there are relation with the femoral puncture location associated with the complication. Low stick, what do you mean by low stick? Puncture below the femoral bifurcation. There you may end up with the pseudoaneurysm, hematoma, arteriovenous fistula. High stick we mean puncturing inferior epigastric artery or above. That retroperitoneal hemorrhage is the risk. Postural puncture through the back wall of the artery. Especially this happens when you fail to compress the artery appropriately. So retroperitoneal hemorrhage could lead. Number of the atoms. First atom is the best atom. 2 atoms better. Complication more than 2 atoms. So shift to the other side. Sheath size. Greater the sheath size, chance of complication is more. There is a study by the Grossman and his colleagues. They found when the sheath size is 7 and 8 French compared to the 6 French, associated more vascular complications. Sheath removal time. Ideally, when as early as possibly remove the sheath. Compression is the best way, just proximal to the site of his skin puncture for at least 30 minutes is ideal. Medications, antiplatelets, oral IV, anticoagulants, those who are receiving, that is a factor. So there are some important considerations in difficult femoral arterial access. There is no hard and fast rule that you have to be always femoralist, you have to be always radialist. You may have to switch over one to others. So you need to know both the techniques very well. So absent or weak femoral pulse. So consider radial artery approach. Doppler needle, or there is a smart needle, which needle is attached to a Doppler probe. You can use in these particular settings. Micropuncture needle can be used in this settings. If there is a history of iliofemoral bypass graft, you can use micropuncture and consider smaller sheets. And you can also consider the radial switch. And there is important prior femoral arterial access and closure device use. If the patient, if have femoral access previously and the collagen-based plug, that angioseal was used, you have to wait 3 months before re-access to the femoral sites. So restriction, but it's not the hard and fast. You have to wait 3 months. You can go 1 centimeter above, and you can, if you have the space, you can go ahead. No restriction if a suture-based like par close or nitinol clip-based star close device used. You don't have to wait. You can reassess. Active groin infection, use the contralateral side, or you can also even consider radial side. Prior groin surgery, excessively scarring, use as a radiotherapy, use contralateral femoral artery, or you can consider the radial side. Tortuous iliofemoral arterial system, you can consider radial artery, or you can use a very longer sheet once arterial access is obtained. Calcified common femoral artery, consider contralateral femoral artery if less calcified. Calcified common femoral artery, consider contralateral femoral artery. Known aneurysm of the iliofemoral or aortoiliac system, consider radial approach. Consider use of exchange length wires for all catheter exchange. If the patient have severe back pain, inability to lie flat for prolonged periods of time, consider radial approach, or consider a closer device where you can make the patient early mobilize. So morbidly obese patient, they are the difficult patient. Consider radial arterial approach, or you can consider micropuncture or a smart needle to have your puncture. So now the question of the hematoma. This is something, collection of the blood in the soft tissue. Most common vascular complication, 5 to 20% may happen. Pain, swelling, and induration is the features. So you look at this in the figures. So if you found a hematoma, you give a border. So you can check whether the size is increasing. Hematoma greater than 4 into 5 centimeter, this is alarming. If hematoma associated with distal pulse become diminished, this is alarming. And are unable to control or manage bleeding, this is alarming. So you need to, not all hematoma is benign, at the same time you need to know which are the hematomas you need to intervene. So this is the way. So loss of blood under the skin directly as a result of arterial or venous injury. Stable hematoma may require no more than marking the boundaries. That means hemodynamically stable, size is not increasing, patient is fine, you just mark and watch. Unstable hematoma, you have to give the direct pressure, 1 to 2 centimeters superior or inferior, depending on the insertion site, on the origin of the bleeding, arterial or venous. Monitor the vital signs. So these are the way, how can you assess the bleeding risk, major, minor, or minimal by TIMI bleeding definitions. I'm not going details, or gusto bleeding definitions. But the parameters they follow in TIMI is the hemoglobin and the hematocrit. More than 5 gram hemoglobin down, more than 15% down, this is major. More than 3 gram down, this is minor. And more than 10% decrease, minor. So question arises when you intervene. And in the gusto, when there is hemodynamically stable patient requiring blood transfusion but hemodynamically stable, this means severe. When this is hemodynamically unstable, this is a severe or life-threatening condition. So another complication is the pseudoaneurysm, a contained rupture with disruption of all 3 layers of the arterial wall. When an arterial puncture site does not adequately seal, so they are, how clinically we assess, pulsatile blood tracks into the perivascular space and is contained by perivascular structures, which then take on the appearance of a sac. That's the figure, nicely shown, the femoral pseudoaneurysm. And the factors, which are the factors? As I already mentioned, that this is a low stick puncture. This could happen, and the antiplatelet agents, anticoagulations, large sheet size, age is a factor, obesity factor, poor post-procedural compression is a factor, simultaneous artery and vein catheterization is a factor, hypertension, peripheral arterial disease, hemodialysis, complex intervention, these are all the factors. So clinically, the pain, swelling, puncture site. And sometimes patients also have the compression features. If the venous compression, there may patient comes with the DVT. If the arterial compression comes with the acute limb ischemia. If the compression in the femoral nerve, they may comes with the neuropathy. So that there may be features of compression. That's because this is enlarging. Sometimes you may not have any features. So imaging duplex ultrasound is a very quite sensitive and specific. You can diagnose, and these are the features. In the left panel, you can see the ultrasound diagnosed pseudoaneurysm. Treatment until 90, there was only surgery, but we have now other options like ultrasonography guided compression, ultrasound guided thrombin injection, femostep compression device, coil insertion, fibrin adhesive. So there are multiple options depending on the situations. Ultrasound compression is also a sensitive one. We can go ahead, but if the patient on anticoagulation, success rate may not be as great as in shown here. So this is advantage and disadvantage. And also thrombin injection can be also done. This is also have a very high success rate. And there is endoluminal management. This is by the covered stand or the embolization. You can use this one. Coil closer, when the neck is narrow, we can use the coil closer also. And surgery, if there is infected pseudoaneurysm, rapid expansion, failure for all other therapies, as I mentioned, there is skin necrosis or there is compressive syndrome like neuropathy, claudication, or critical ischemia, then you have to put the surgery. This is the unfortunate patient. This have to done. So prevention is the best thing you can do. So assure needle puncture in the proper location, achieve vascular access on the first puncture without access through the posterior wall. Appropriate groin compression after sheath removal. This thing you can prevent this awkward situation. Retroperitoneal hematoma. This is if you have a puncture is a high up, and then you may complicate with this retroperitoneal hematoma. Incidence 0.1 to 2%. This is a high puncture, I said already. And the fact that patients receive antiplatelets and anticoagulants, they are more risk. And high index of suspicion is needed because initially may not have symptom, only low back pain or something like that. If the patient is tachycardia, hypotension, you may have to suspicion. And retroperitoneal hematoma near or within the iliopsoas muscle can present as a femoral neuropathy. Sudden severe pain may affect groin and lip may possible. So there are a number of imaging modalities we can find. Ultrasonography, CT scan, CT angiogram, even MRI angiography also may be needed. So basically we have to first try the conservative fluid resuscitation and blood transfusion. And there is no specific guideline to suggest when to intervene. So patient is hemodynamically stable, conservative. Hemodynamically non-stable, then we have to think about. So endovascular treatments, again, question of the comes of the covered stand or the embolization. And open surgery when the conservative treatment is also fails. So there is another one is the arteriovenous fistula. So as I mentioned, if you prick the superficial femoral artery where the femoral veins are nearby located, there you may end up with the arteriovenous fistula. Abnormal connection. So risk factors are female, hypertension and anticoagulation, low multiple punctures, obesity, advanced age, low groin puncture, and sheet placement. These are the two important that we can avoid because there are the excess superficial femoral artery just distal to the common femoral bifurcation, and profunda femoris vein passes between the superficial artery and profunda femoris artery. So incidence is like less than 1%, initially silent, 2 days to several months, and there may be abnormal sensation. Patient may exhibit lower extremity edema, and there may not have any symptoms. If it is a significant one, patient may have even features of the Steele syndrome like that. And palpation and auscultation is an important subset. Where is continuous machinery murmur, Brui hematoma, all this is present. So treatment, most small asymptomatic fistula thrombus spontaneously, and you need not to treat. But if there is heart failure, there is progressive, there is iatrogenic, then you have to treat. And the ultrasound guided compression may not help like other situation. Endovascular repair like covered stent or embolization may be necessary. There may be very rarely arterial occlusion. There may be features of arterial occlusion like pain, valvuloparesthesia, pulseless, especially large catheter most likely used in a small common femoral artery. Diabetes patient, female patient, this may happen. Infection less than 1%, and most commonly it is due to improper shaving and improper scrubbing. So they need to shave and scrub very well, and antibiotics, and prevention by appropriate shaving and scrubbing uses sterile dabs. Femoral neuropathy is also less than 0.3%. This is relatively uncommon. Compression of the femoral nerve, tingling, numbness, but usually self-remitting. No need to have to treat. So at times we have to also use the femoral venous access. This is similar, the anatomy. So only this, you have to go medial from the arterial pulsation, 1 or 2 centimeter medial, and you take all other likes. And you have to keep a syringe with you so that when there is a puncture, you can have a backflush, because arterial flow have a continuous backflush. You may have to aspirate here to make sure that you have a proper position. This is very important for the fellows because on and off you have to do temporary pacemaker at the odd hours. So you need to be a master of this. So this is not the all over of the access, because you have successfully done the puncture. Now you have to successfully close it. So manual compression, worldwide manual compression is the most commonly used technique. Sheet should be left for the least amount of time to avoid risk of thrombotic vascular complication and bleeding. When anticoagulants are used for the procedure, the sheet should be removed when the active platelet clotting time is less than 150 or 160. That means when you are doing PCI and you do the ACT and when it is less than 150 or 160 seconds. So manual compression, patient should be moved closer to the side edge, and patient bed should be lowered. Patient should be connected to a monitor to assess the heart rate continuously. Blood pressure initially every 2 minutes. Ready with the medication in case of vasovagal reaction. Under sterile precaution and sutures holding the sheet, plates are removed. Sheet is allowed to bleed back briefly to expel any thrombus. An artery palpated from the skin neck, and with gentle pressure over the artery with the fingertips, sheet is removed with the other hand, allowing for the back bleeding to flush. And manual compression applied to the fingertip with 3 fingers approached from the skin, and also same time you feel for the distal pulse is preserved. Alternately, a roll gauze placed along the length of the, and with the palm of the hand you compress. There is a rough rule for each French you hold for 5 minutes. There you use 6 French, so you have to use 25 minutes or 30 minutes like that. A pressure reduced during the last 5 minutes, compression up to 25% of the initial pressure. Actually, what we do here, we give us, if initial pressure is 100%, every 5 or 10 minutes we decrease by 25%. So by this way we do it. So manual compression, one hemostasis is achieved, the distal pulse you have to palpate to ensure the limb perfusion. Advantage of manual compression is associated with the lowest vascular complication rate. Disadvantages are discomfort associated with the sheet removal, inability to tolerate prolonged supine position due to variety of comorbid conditions. So when the question of vascular closure device arises, so when we put the patient on manual compression, we have to keep the patient for 30 minutes, 40 minutes, depending on the sheet for compression. And the question arises for the bed rest. This is another roughly for one size sheet. You have to ask the patient to bed rest for 1 hour. So 6 French sheet, you have to put the patient in bed at least for 6 hours. So when you use the vascular closure device, these are you can early immobilize, and you don't have to keep the people around here to compress the artery. So variety of assisted compression devices are available that can help to achieve hemostasis non-invasively or used as an adjunct to manual compression. These include mechanical compression device such as the femostep, radio step like this. Though in our country, we are mostly done by manual compression. So contraindication to use the vascular compression, low puncture, you cannot because increased risk of ischemic complication. High puncture above the level of the inferiority, you cannot because 2.8 times the risk of retroperitoneal hemorrhage. Patient with moderate to severe peripheral artery disease, you cannot. Patient with a smaller femoral artery, you should not. Patient with diabetes mellitus and other immunodeficiencies, you should not because of risk of infection. Patient who not allergic beef products, you should not the angiosil where they use the collagen from the beef source. So these are some pictures where locate the arteriotomy site by angiosil and see the anchor and the site of the collagen plaque. And Parclose deployment, positive position of the device, and use the snare knot push for the deployment of the suture. These have certain learning curves and each have its own merits and demerits. So these are only in limited use in our country. Star close deployment device, these last two devices can be, these patients can use again if needed for the but if there is angiosil, you have to wait 30 days, minimum 3 months, 90 days we have to wait for reassess. This is a real life scenario where we have patients, we have done the, actually this was a CTO patient we have done, and through the radial artery, we have done the angiography and we found there is the total occlusion. And to see the collateral very well, we are now going to the femoral. So educatedly, we try to first make a bleb of the local anesthesia, and then we fanning out and give them so that educate local anesthesia. And taking care not to push the local anesthetic directly to the vessel. And after doing that, we try to, most often those who are experienced operator, they can go directly, but to avoid the complication and to hit, because there is the bifurcation that we have shown, that is not always down, it may change. And the relation between vein, artery, nerve, they are not always the same. At times vein overlap. So there are the situations, but we need to locate the femoral head inferior. So as I see here, and then I go up to the lower end of the femoral head. So I have to puncture in such a way 2 centimeters below, so that I can hit the midway between the superior and inferior borders, and so that and when we cross the resistance, we try to feel the arterial pulse through the needle, and it can be if you go slowly, you can feel that the artery is pulsatile through your needle, and then you gently push so that you have a just anterior puncture, and you can see the gush of blood is coming out, and then you use the J-tip wire. So after J-tip wire, then you see in the fluoroscopy to check that you are going in the correct manner, so that you go to the common iliac and then to the abdominal aorta, and you go to the left side of the vertebral column, so you can sure that. Then ideally you do the femoral angiogram to check that whether you are in a, you see that my stick is here, is a midway between the femoral superior and inferior border, and the bifurcation is far away. So in this way, you can really avoid the complications. Sometimes due to anatomic variations, many of the advanced countries, they are using actually Doppler probe to identify the bifurcation, whether they are in the correct location. Otherwise, if the bifurcation is high, even if you use the fluoroscopy, you may enter the common femoral or profunda femoris or superficial femoral artery. That's why the ultrasound probe is nicely because it is it's not compressible, and the triphasic flow and the bifurcation is nicely shown. So you can use the ultrasound probe in this complicated patient. This is especially those who are very obese and complicated cases. So with these few words, I'm at the end of my talk. Femoral root is still not a forgotten root, one of the commonly used method in many of the countries, and vascular complication through relatively high but can be avoidable. For performing procedure through the femoral root, it is important to follow every step meticulously so that you cannot land up with a complication. So thank you very much for your kind attention. I'd like to end here.
Thank you, Anis. Excellent presentation and brilliant demonstration. I think all the fellows are benefited for your presentation. After nice talk, you see the demonstration. Thank you, Anis. I'm really proud of you. You're my roommate.
And it's very well done. Very well done.
Very well done, Anis. I think IPDI started the journey with a dream. With the Cathlab manual, I think it becomes true within a few, within after 3 months. Wadud sir, any comments regarding the lecture?
No, Anis has provided such a detailed description and given such a beautiful presentation. I'm amazed and very happy. That much I could say. Any question about it?
Dr. Ashish De? Do you hear me? Yeah. Yeah.
And thank you, Dr. Mohsin and Wadud sir and IPDI for inviting me, and also I think it's a great educational platform for not only the fellows, but also for me also. I am also learning, and our teachers, legendary teacher Mohsin Ahmed sir, Kaisar bhai, Wadud sir, and also Mohsin sir also there, and I am also still learning. And Anis, regarding Anis' presentation, Anis also beautifully shown about the femoral puncture. Though it is time for radial, everyone goes for radial. We also started femoral because femoral should not be forgotten. Because as he mentioned that in the odd time when I do a temporary pacemaker, and also the femoral root is very much essential, femoral vein puncture. One thing for the fellows, I want to mention that before beginning the puncture, just show with the fluoro, the lower part of the head of the femur should be seen, and the needle puncture should be at the middle and lower third of the femoral head. Inadvertently, when a femoral vein puncture is done, then I want to share my experience that just keep it the wire in the femoral vein. Then it keeps as a guide, just puncture the medial to the guide wire, then we can make the femoral artery puncture. If inadvertently femoral vein punctures done. Okay. and also all the complication and management Anis mentioned, so nothing left for this. And also again thank IPDI and also Wadud sir and also Mohsin for inviting me, and also thank for giving me the opportunity to talk, say something. Thank you again.
Professor Masud Chowdhury from ICRI, Ibrahim Heart Center, Cardiac Heart Center. Professor Masud Chowdhury.
Yes, thank you. First of all, I must congratulate the organizer for starting such a nice program. And I already, many of them told that it's not for the fellow. We also learned a lot regarding Dr. Manwar's eco pre as a pre-cath test. I do remember starting in the ICVD, Mohsin Ahmed sir used to, when he used to take the patient first to the echo room, and with us he used to see the echo, then he used to take the patient into the cath lab. So from that point, we still remember the pre-cath echo room, and Dr. Manwar has very nicely given details regarding this. And Dr. Anis, recently the fellows used to start with radial, when in some case they need, we say that go through femoral, they feel hesitate to start femoral, then do radial. So all should learn and may consider to start with radial. Thank all the organizers and all the panelists for their contribution. Thank you.
Thank you. Thank you, Huay. Dr. Ashut Datto. Dr. Ashut Datto.
Thank you, Dr. Mohsin. So, Dr. Anis, very good presentation and detailed presentation. I have one question to the all panelists and all the audience regarding the angiosil use in their clinical practice. Have you, any one of you, have got the idea or personal experience regarding use of angiosil? Number one. Number two, regarding fluoro-guided puncture, and puncture by filling the radial artery by pulse by fingers. And third is ultrasonography guided puncture. I will ask our seniors, those who are in the panel, what about their feelings regarding fluoro-guided and pulsation guided puncture? Which one is better?
I think Professor Mohsin sir used the angiosil because TAVI is done TAVI. So Professor Mohsin sir, comment on the angiosil because TAVI must be the angiosil. Yes.
Angiosil basically, angiosil initially I used to use some patient, especially in femoral root, definitely. But nowadays, because of the patient demand and switch to a radial, rarely we think about femoral. But the question is that use of angiosil. Yes, angiosil is a very simple procedure, and I think it doesn't need much of learning curve because the device itself is
what about the cost,
so simple. Sorry?
Versus low cost.
Oh, the hospital charged 20,000 for the device.
So sometimes it is costlier than the angiogram itself.
Yes. No, usually we use, especially after intervention, and the patient can afford it, obese patient, we used to use this. And second question is about
fluoro-guided and
fluoro-guided versus, I will just give one shot to you. Are you seeing it?
Yes, sir.
Yes.
I think this is fluoro-guided. No. Just a minute. This is fluoro-guided.
Can you make it a bit bigger, sir, with slide mode, sir?
Sure. This is fluoro-guided.
Thank you.
This is fluoro-guided. Is the junction of medial or 1/3 and lateral to 1/3. You see, you can easily see it.
Yes.
This is fluoro-guided. But nowadays, I think rarely we practice this because the pulsation, femoral artery pulsation is so big. So it is barely, you will have any difficulty to identify the pulse location, except in some situation where there is very feeble pulse with obstruction in the iliofemoral area above the area of puncture. Then you need to locate it by fluoroscopy. After repeated puncture, you are not getting the access. In that case, you can use the fluoro-guided use of. Regarding ultrasound, I don't have any experience of ultrasound.
Thank you, sir.
Thank you.
Regarding angiosil, it is priced about, I think, 15,000 rupees, I think so, 14,000 or 15,000 rupees. But it's so much painful for the patient. Sir, your experience about the patient's painful of the angiosil. Because it is a hemostasis, not so painful, but angiosil, patient is feeling of pain regarding the, sir.
No, it is not that much painful. Thing is that, yes, if the effect of your lignocaine is over, then patient may get some experience of pain, but usually not that much.
Yeah, thank you. Dr. Manjur, you have a question, I think so. Abdul Manjur, you have a question? Dr. Manjur, do you hear me? Dr. Manjur, you have a question?
Sir. Yes, sir. Thank you, sir.
Yes.
Thank you. It's my privilege to participate here. Actually, sir, IPDI is proving day by day the webinar is more fruitful than the real-time class. I think so, sir, because especially for beginner like us. So regarding femoral puncture, what I experienced for the last 3 to 3 years, we should, sir, should we avoid through and through puncture? What we can
Always.
It's my actually not, it's my from my experience. If we avoid through and through puncture, then femoral puncture complication will be less. I think so, sir. So what do you think, sir? And another question for Mohsin, sir. Sir is still sir, what sir using angiosil, and is he find any definite difference between manual compression and angiosil, which cost more than 40,000 taka?
No. Nowadays, I have got no experience for last 5 years, almost.
Thank you. And so regarding, sir, angiosil, the puncture site is very much important. If we puncture the lateral wall, anyhow, more lateral or more medial rather than anterior wall, I think angiosil may be difficult to make a good hemostasis. That is very important. Another thing is someone try to avoid the posterior wall puncture, but it is, if you are confused that whether in the artery totally or not, it is better to puncture the double wall rather to puncture several times to puncture the anterior wall. So single puncture, even if it is through and through the wall, it is better than the multiple puncture. What is your opinion, sir?
You're right. But it is more important is the location of the
anterior or lateral wall puncture.
But it is more important the branch, the distance between the bifurcation of superficial and profunda. This is very important. At least it should be at least 1 centimeter above puncture. Otherwise, it can interfere in the flow for the profunda. Lateral, whatever the way, because the seal is such that you are going to the same route with a single puncture, you are sealing the same route. Once you remove the sheath, keeping the wire inside, and then angiosil proceed further, then what will happen? The angiosil itself, there is a knock like this. It will lock within the wall, either in the lateral wall or in the anterior wall. But rarely we puncture the lateral wall. Mostly we puncture the medial wall, anterior wall. So I think instead of lateral or medial, is more important the bifurcation. Bifurcation.
Khaled has some experience, I think.
your comment, Khaled, Mr. Yeah.
Regarding the use of angiosil, sometimes there is a failure of angiosil. So when you are going to use the angiosil, you must have a backup device in hand. It is called the femostop. If you don't have a femostop and your angiosil fails, you will have trouble after a PCI because the patient is already anticoagulated and it is a real problem. So femostop backup is it's a mandatory if you are going to use the angiosil or a other suture device or something like that. There's something there is a possible chance of failure. And regarding the use of, I want to thank Dr. Anisur Awal for his brilliant lecture. So in cases of obese female with a low inguinal disease and with a femoral bruit, we have to be very careful. We have to anticipate some trouble. And in case of patient hypertension, in case of post femoral puncture hematoma, I think the majority of the patient has uncontrolled blood pressure. So we need to control the blood pressure very well before we do the hemostasis. And another thing is to prevent the femoral complications. In many countries, they use a 4 French diagnostic sheath and they use no heparin. So it also adds to the safety margin. And these are the things we should keep in mind. And I think the femoral has still got a role, but we should, the role is gradually declining day by day. Thank you very much.
Sir, I want to ask you a question, sir.
Yes.
Sir.
Yeah.
Thank you, Anis bhai, for your excellent presentation and elaborate presentation. The operator who is dealing with more complex procedure, he is very fond with femoral access because the more difficult case is more comfortable in the femoral route. On behalf of fellows, I want to ask a question to Anis bhai. Some of the cases in elderly patients, usually mostly in the male, we found the femoral artery is highly tortuous and calcified, plaques is visualized to fluoroscope. So in a beginner or those who have started doing femoral angiogram, how they can overcome this procedure, I want to know step by step so that they can keep it in their mind and they can apply it in the practical field. Highly tortuous and calcified femoral artery.
That is using of the sheath. Using of the sheath. I think it's sheath and wire.
Sheath, wire, everything. Sheath, wire, guiding diagnostic catheter.
Thank you, Shajol, for a nice question.
Beyond the puncture.
Yeah. So if you have found that there is a calcification and also excessive tortuosity, so yeah, so you can use first you can use the micropuncture needle. You can use, and you can use a long sheet to overcome this, and you can also use the other side also, and you have the option also to switch over also. So you first try in your own side with the puncture and use the longer sheet so that you can overcome the tortuosity. But if it is not, then you can check for the other side. If it is not, then you can go to the radial side. So I think Mohsin sir can supplement this question.
Yeah.
Also use a thermo wire. That's a helpful thing.
I will just share one more. Actually, tortuous vessel, while passing the wire, you can, you see, this is a situation where it is very difficult to pass the single wire. While passing the first wire, you will find that it's very difficult to cannulate with the wire. So what you need to do, in that case, you can go by 2 ways. One, you can use a long sheath. Second one, you can put another wire to straighten the vessel. But things should be under fluoroscopic guide. Never push it blindly, because the tortuous vessel is this. If you push it, there will be kinking of the wire itself, and that wire will again produce trouble to further tracking the sheath over the wire. So from the very beginning of pushing the wire, and the first time you will find some resistance. The wire is not passing. So see on fluoroscopy, you will find a sinuous curve. In that case, you will use a normal 5 French sheath, normal ordinary 5 French sheath. Then through the sheath, you can use another 3-5 wire to make the vessel straight. And once the vessel is straight, then you can, under fluoroscopic guide, you can push the desired sheath, whatever you like. If you feel it would do intervention, then you need a long sheath, because either way, both diagnostic and intervention, as you are controlling from the femoral, because of the tortuosity, the catheter control is very difficult. So it is not like 1:1 torque. It will be very difficult. In that case, it is preferable to use a long sheath to prevent this friction because of the tortuosity. That you can avoid.
So Kaisar,
that sheet, long sheet actually acts as a guide extension, like something like that.
Yes.
Yeah.
Partially.
There are several types of long sheath. One is 23 centimeter. Other one is a 70. 71. You can go up to ascending aorta.
Yes.
Up to descending aorta, close to subclavian.
So another question on behalf of fellows. Should I ask her?
Yes.
What we do from the when we started beginning of angiogram, initially we try to engage the catheter in a first shot. So and there are lots of problem with this and with complications. So what will be your suggestion in this issue? Why we should first do the first shot and how we will engage initially at initial part of the practice? It's very dangerous sometimes. What is your suggestion?
It is not today's discussion. Okay.
Are you asking me?
Yes, yes, sir.
Oh.
But let us keep this answer later on, sir, because there will be a presentation on it. There will be a presentation on it.
I think on this issue of femoral puncture, I give a small few comments. One is that the femoral puncture, usually we use metallic needle, and metallic needle is very much compatible with metallic wire. But sometimes somebody may think that the wire is not going to take a Terimo wire. This is a wrong idea. Don't use Terimo wire through a metallic sheet, metallic puncture needle, because
only vascular sheet. Yeah.
The Terimo wire, if you pull and push, there will be spill off of the coating, and that will remain there. So never use. It is preferable to use plastic cannula. Second one is that nowadays femoral puncture hemostasis is mostly done by Cathlab technician assistants, even sister. I have seen in my practice in India, usually it has been done by nurse. Here in our situation, both nurse and technician or assistant technician are doing it. But before leaving the cath lab, the operator should check first that hemostasis is done properly. Second thing, in post procedure, they must be monitor the patient complaint, either in the leg or in the abdomen, and also monitor the blood pressure. Sometimes they feel that this is nothing but the vasovagal, but it may not be. And patient may be sometime, maybe you see pallor within the cath lab. That means there is a big hematoma, either retroperitoneal or in the femoral. So these are the things should be considered in mind by the operator. Don't believe on the technician or nurse. There's a small comment.
Yes, very important, sir.
Thank you, sir. Dr. Kaisar, do you hear me? Just one question from the fellows. if somebody punctured the femoral vein, if you do angiogram, what should you do? Number one, if in the PCI, if punctured the femoral vein, what should you do?
Well, if it is an angiogram, if you're given a wire, keep the wire there, do your angiogram, and then take the wire out after doing the angiogram. You don't need to bother about that thing. It will not, a wire doesn't make any big difference for hematoma. Be reassured. For PCI, you can keep a venous channel. It will be better for you for TPM or for inotropes. So you can put a venous sheet, 5-inch sheet, no worries. About the Anis lecture, he is a dynamic intervention cardiologist of my hometown, Chittagong. Really impressed. Anis, excellent job done. And I would like to add one thing about the tortuous and difficult femoral artery for fellows. We can use the N+ wire. It's a very stiff wire. Instead of 3-5 wire, we can use N+ wire. Then it will be easier to take your guiding catheter or diagnostic catheter up when you're dealing with a very tortuous artery. Thanks.
Thank you. I add something. If you puncture the femoral vein, if pull out, sometimes somebody pull out a little, then puncture again the femoral artery. He removed the puncture needle, again you puncture. But sometimes somebody puncture the femoral vein or artery puncture, then it's not remove the needle, just goes to the another flow. Then when sheath is given, it causes the fistula, causing the arterial fistula, and sheath removal is the PCI. Exactly. After PCI next day, causing the fistula. So should remove the sheath. Like I said, very more comments regarding this.
Yeah. Sorry, then I couldn't get you. If the wire goes from artery to vein,
yes,
he punctured both artery and vein, then the wire should be removed, and you put a compression for 5 minutes, then you can repuncture. But if you're puncturing an artery and accidentally it went to a femoral vein, then it doesn't matter. You can keep the wire, and after the procedure you can take it out. Or if it is a PCI, then you can put a sheet and
No, he wasn't actually saying the needle. The needle going in, actually he passed from the artery to the vein. He thought the blood is coming venous. Just take out the needle a bit and then go in. That should not be done. The needle, take out the needle fully and do it properly. That way you miss the chance of creating a fistula.
Actually, what happens initially, if someone punctured the femoral vein, and usually artery is closed and a bit lateral to the vein. Not necessarily you have to come out through and through from the skin. You have to come out from the vein in the subcutaneous tissue, but no need to remove the needle totally. Then you can go laterally.
For the fellows, I think should to remove, because for the beginner training period must be punctured the femoral artery at least 90% cases. First time punctured, femoral puncture is anterior wall. Should practice confident to puncture the femoral artery in the first time anterior puncture. He should practice. Mohsin sir.
Just one small comment on this.
Yeah.
My practice usually, if I plan to do femoral vein puncture, usually I use a syringe with a saline syringe, so that the negative suction and slowly push. So if there is no chance, even say middle of the night, the fellow there, the patient came with complete heart block, he may need to go for femoral access for TPM. So in that case, instead of straightway using the cannula, you can use a syringe feed with saline and puncture with a negative suction. So in that case, once it is in the artery, it will immediately, you will feel sudden relief of the pressure. But in the venous, the very, we will say it is in the vein. So for the venous puncture, if you want to do deliberately for venous puncture, use syringe. For the arterial puncture, is definitely anterior wall puncture is the main intention. So go slowly, and you can understand that there is no need to push the whole length of the needle down within the thigh, because it is not. It should not be not more than will be 2 or 3 centimeters from the skin. So this way you can avoid arteriovenous connection.
Thank you, sir.
Can I add something?
Yes, sir.
Very often, the proper position of the leg should be maintained, because if the leg is like this, your femoral head is in not proper place. The foot should be like this, laterally rotated. Only then femoral head come under the femoral artery. That's a simple anatomical rule you should follow. Do not keep the foot like straight up. It should be laterally rotated. The whole leg should be rotated laterally. And then palpate it and puncture the femoral artery, anterior wall.
Thank you, sir. We are 2.5 hours, I think, lots of time.
Don't you end it?
Our announcement next class on the 8th September. 8th September.
From 8 to 11:15, 3.5 15.
3.5 hours.
3.5 hours almost.
Next, from the next month, I be a class only on Thursday at 9 p.m. So Friday we relax, enjoy with our family. So next class on 8th October, my friend Dr. Khanduga Asad is the best person to talk on the radial access. Guide to 100% success access project. Number 1 lecture, and radial artery spasm, tortuosity, how deal with crossing radial artery by Dr. Khanduga. Then Dr. Juman Boni will talk on anomalous coronary artery, how to deal, and also draft vessel angiogram. Then Dr. Ashok Dotto here, he will talk on coronary angiogram view, coronary artery severity assessment, and ideal coronary angiogram report. I think excellent talk. Dr. Thanks everybody. For this, sir, Dr. Khanduga, Asad, you talk. Any comments? Ready for next day?
Well, the bar is raised today, so you have to be careful. Asad, unmute yourself.
Unmute.
Yes, sir. Thank you. Actually, it's late, but I want to add some comments. Answer by 2 presenters. First one, what should the approach of the angiogram of the patient having menstrual phase? In this case, it is our practice, particularly in the private sector, the patient was due to one-day practice, and
আসাদ শুনতে পাচ্ছি না।
শুনতে পাচ্ছি না।
Sir, can you hear me, sir?
Yes.
Yeah, now.
Yes. Actually, we face some problem regarding the issue. First issue, that is the menstruating lady. When a lady gets admitted in a declared package, one-day package, and suddenly we notice that she is menstruating. In that case, what our strategy? I want to share it. Now, number one, we use all these things. The newer one, that is the from the vascular access sheet, catheter or guide wire, everything is the new first one. Second, we should avoid the use of heparin. Third one, we should try to minimize the time. All these things, by covering all these things, we should complete the angiographic procedure. My supplementation. And number 2 issue that is not solved yet. What should be the guide catheter in a according to the size of the root of the aorta? Actually, if the size of the root of the aorta is 5 millimeter, that is in the sinotubular junction, which is less than 35 millimeter, consider it is a narrow aortic root. Select the catheter, that is the second arm of the catheter should be the 3, that is 3 size catheter. And if it is 3.5, that is 35 to 40 millimeter, and then we should consider it as a normal root aorta. And in that case, we should select 3.5 carb catheter. And if it is more than 40 millimeter, that is 4 centimeters. In that case, it is considered the 4 or more size catheter. This is my comments, and actually all the presentations from all the presenters was excellent, and interactive session was very excellent. I enjoyed a lot. Thank you, Mohsin bhai, and thank you, Prof. Wadud sir, for initiation this types of session and do this late. Thank you, everybody.
Thank you, everybody. Wadud sir, I really IPDI proud of Dr. Nur Alam, Dr. Monwar, Dr. Anis. They are our younger brother. You direct teacher, you are the direct teacher. So excellent presentation. We start our job very well, sir. Sir, thank you, Mohsin sir. Wadud sir, please comment and conclude the session.
আমার কিন্তু একটা কমেন্ট আছে আমরা যে 3টা করে লেকচার নেওয়া কি সম্ভব হবে কারণ ডিসকাশনটা অনেক ভ্যালুয়েবল হয়
Exactly.
I think 2 lectures are better. Then we can have a heart-to-heart talk. The wisdom that we gain from Mohsin Bhai's and other people's experiences, we cannot get that from a lecture. Mohsin, you should consider that.
Yes.
Because knowledge when used and modified by experience, that's wisdom.
Yes.
We need wisdom, not only knowledge.
Yes, thank you, sir.
And as a whole, I think nearly 100 people waiting till the end, that speaks volume of the quality of the lecture that has been given. All 3 presenters, we are extremely grateful to you. And also we are grateful to Beximco Pharma, who are toiling with us till this late night. And Mohsin Bhai, you are an idol. Thank you, sir.
Thank you. Thank you.
Thank you, everybody. Thank you, Beximco Pharma. Thank you, Dr. Arif. Thank you, everybody. Assalamu alaikum. Goodbye. See you on 8th October, Thursday at 9 p.m. Till then, goodbye. Assalamu alaikum.
Inshallah.
Thank you, sir.
Allah Hafiz.
Thank you. Thank you.
Good night.
Good night.
চয়ন কি রে ভালো আছিস
স্যার ভালো আছেন স্যার
আছি রে
এক্সিলেন্ট স্যার অনেক ভালো স্যার আপনি যেটা বললেন 2টা করে লেকচার হলে আমাদের আরো ভালো হয় আর কি ভালো ডিসকাশন করতে আরো মানে আপনাদের এক্সপেরিয়েন্স গুলো শুনতে পারি স্যার আমরা
এটা বোধহয় মহসিন একটু বিবেচনা করে আমার মনে হচ্ছে 2টো করে লেকচার নিয়ে আসো লাগুক অসুবিধা নেই মাঝে মাঝে তুমি কোনো সপ্তাহে 2টো করে দিয়ে দিও ছুটির দিন পাওয়া গেলে
জি স্যার জি স্যার
Okay, sir.
I think we have to consider this issue.
And Anis, I'm really amazed.
Thank you, Anis. Also, Nur Alam and Monwar.
Nur Alam তো তাও তোমার আমরা রেগুলার দেখে অভ্যস্ত হয়ে গেছো ভালো লেকচার দেয় আর মনওয়ার তো এক্সট্রাঅর্ডিনারি সেটা আমরা জানি আনিস আজকে দেখালো কেমন হারে সমান লড়িচ্ছে দুজনে সমানে সমান বাবা এক্সেলেন্ট
Beximco Pharma, thank you.
Thank you.
Thank you, sir.
Good night.
Assalamu alaikum, sir.